看得到？Is it showing？ live就好了。Okay. Good evening, everyone. On behalf of ManaDr, OtterSG, and Lifepack, I would like to warmly welcome all doctors and healthcare professionals joining us tonight from Singapore, Indonesia, and across the region. Thank you for taking out of your busy schedule to be with us tonight. CME Webinar, Advanced Primary Care Practice from Infectious Diseases to Aging Population Management. Tonight's webinar brings together several important and highly practical topics relevant to everyday primary care practice. From holistic care in an aging population to CT-based cardiac imaging in cardiovascular risk management, as well as dengue prevention and public health strategy within Indonesia context. We are honored to have an excellent lineup of speakers joining us tonight, and we hope that the session will be insightful, practical, and clinically useful for all participants. Before we begin, just a few quick housekeeping announcements. Firstly, throughout the webinar, feel free to submit your question through the Q&A or chat session. We will try our best to address as many questions as possible during the discussion sessions. Secondly, for doctors attending the CME accreditation purposes, please note that the attendance form will be released during the middle portion of the webinar. We kindly encourage everyone to fill in the attendance form once it is shared in order to facilitate the processing of your CME attendance endpoint. And finally, we sincerely thanks all of you for spending your evening with us, and we hope tonight's session we will provide valuable learning and meaningful discussion opportunity for everyone. Without further delay, let me introduce the first speaker. So our first speaker for tonight is Dr. Siaw Yeng. Dr. Siaw is a senior family medicine specialist with more than 36 years of experience in clinical practice and medical informatics. He is also the founder and CEO of Mobile Health Network Solution and has contributed extensively to Singapore healthcare landscape through various Ministry of Health task forces and advisory communities focusing on medical information and telemedicine. Tonight, Dr. Siaw will be sharing on holistic primary care in an aging population. As primary care physician, we are increasingly managing patients with complex chronic diseases, fragility, and long-term care needs. This session will provide valuable practical insight into delivering holistic and patient-centered care in today's aging society. Please join me in welcoming Dr. Siaw. Right. Host, don't mind to bring Dr. Siaw in. Hey, Dr. Siaw, you're live now.
Hello.
Yes, we can hear you.
Can I? Okay, thanks.
Yes.
I will start already, Alfred.
Yes. Thank you, Dr. Siaw.
Okay. Thanks everybody for attending this talk. Now today I want to spend some time on some topic that is actually very dear to my heart. In fact, it is on how we will tackle aging populations, especially in the area of the primary care. Now it is important. I want to share this in the context of a rapidly aging population, not only in Singapore, but in many parts of the world. I have been a family physician for many years. Over the years, I've seen my patients growing old with me. It is indeed a unique privilege to see them not just growing old with me, but at the same time, I can see and help and appreciate and grapple with the problems that they are facing. Now, as doctors, especially for those of us who are in the primary care, it is indeed a privilege to grow old with our patients. It is also indeed a privilege to take care of them, to make sure that as they age, they remain healthy, independent, and fully functional. So that's very important. And this is why I want to share and glean from my years of taking care of them and what I think especially we can together make aging not just some things unique, but also some things sensible to all of us. Now, I put these topics in the context of a holistic primary care in the aging populations. And in fact, I want to set the framework to make sure that at the end of this talk, we can all go back when we encounter a patient that has grown old with us in our clinics setting day to day, may it through virtual care or through physical face-to-face, we can actually start to appreciate and take care of them. Now, it is actually a startling fact. In fact, by the year 2030, 1 in 6 of the people globally will be aged 60 years and older. We will be facing increasing polypharmacy, multiple morbidity if we don't do anything. As one age, we know that there's a higher risk of frailty, for reduction in cognitive function and memory, and above all, loneliness. Now, a lot of times, share has shifted now from dealing with single disease to taking care of the function. And in fact, the most important thing is quality of life. Now, this is why primary care is so important. And I want to emphasize again, very important. It is the anchor to take care of an aging population. Now, in the context of Singapore, it is even more startling. Singapore is one of the world's fastest aging, has one of the world's fastest aging population. In fact, many people may not realize 1 in 5, just by June last year, of the Singapore population is more than 65 years old. By now, we're talking about 1 in 4. Now, we are one of the fastest super age population in the year 2030, 25% of Singapore population will be more than 65 years. Now, this is a very startling fact. What does it tell us? Today, right, 5 working adults will start support and aging. By 2030, we only have 2 working adults. By working, I mean people in the age of 20 to 60s, supporting 2 in 1. Now, you can imagine the pressure point, the disease burden upon us, having to cope with people with increasing frailty, reduction in cognitive functions, and not only that, taking multiple medicine if you don't do anything now. At the same time, we're at the cusp of huge opportunities. Why I say huge in the sense that because we are the forefront to guard this, okay? We're the forefront that we can make a difference before many of them become frail with multiple fracture, reduction in cognitive function. Now, ultimately, as the population age, we also live longer. But it is important for us to remember the goal that we're trying to achieve here is not just longer life. There's no point living a longer life but lying on the bed most of the time. Holistic care will optimize function, resilience, and meaning. We don't look at the elderly based on disease marker, how we manage disease. But I think it is important to look at them from the various aspects of medical, functional, mental, social, as well as purpose. Now, I want to deep dive a little bit into that. Looking from the lens of a holistic care in dealing with an elderly population, okay? Now, many of us, as we grapple with them as they grow older in the early days, we look at them from the medical lens, whether they have diabetes, hypertension, other chronic disease. Okay, we spend much less time on primary prevention. Even worse, we don't look at how well our patient is functionally because patients in their 40, 50 never bother about us. they work well, they play well, they have good memories. But it is also, this is the golden period where we intervene to make sure that as they age, they are functionally independent. Now, today, the patient that comes to us, it is no longer, please no longer look at them from the lens of medical, whether they are in their 30, 40. We should ask ourselves, we want to make sure that our 30 years old, our 40 years old, when they age, when they are 60, they are functionally well. They have the best of the muscle, the best of the bone structures, the best of the joint. We do not want to deal with them when they have the problems. Now, in terms of mental, many of us forget that primary care actually go beyond medical and functional. It is actually very important to look at the moods, the memory, the cognition, how well our patient is coping with life. Now, in fact, I would dare to venture that the first thing in our encounter with our patient is, how are you today? Not so much as why do you come and see me? What is your presenting complaint? Cough, cold, running nose, diabetes, hypertension. I think we are at a position of privilege and strength to ask our patients, how are you coping with life now? Now, this is something extremely pertinent. From my years of experience as a primary care physician who are deeply involved in my patient care, I think the most touching question in a patient encounter, we should change the dictionary of how we treat our patient, how we ask our question. Rather than asking the patient, what is your presenting complaint? I think many of us should spare a thought and ask this question, how are you coping with life? We should never assume that a 30 years old, a 40 years old, or 50 years old are coping well. In fact, at any point in time, if you are asked this question, you will find that your consultation normally will spring from a few minutes to maybe even half an hour or 1 hour. Many of our patients carry with them the burden of mental health, the burden of being able to cope with life. Now, socially, it is important because we can't be Superman, okay? We can't take care of our patients very well. We have to rope in their families. Patient has close friends. Patient, if they don't have, we have to rope in the societal supports. Now, it is very important. Many of the elderly, as they grow old with me, I find that they are increasingly lonely. Okay, they have to stay their home by themselves. In fact, many elderly in Singapore, many of my patients, despite having children of their own, they are staying alone at home. Imagine a 70, 80 years old patient staying in the same household. The children has grown up and live on their own, and many of them have lost their spouses. Now, this is why I say in a holistic lens, we have to look at our patient as a human being, no longer as a disease entity where we are taught to be, where we used to medical school to teach us. Now, it is also very important to touch on the lifestyles. You will see many of our patients, okay, elderly are not eating very well, despite the fact that even in Singapore, okay, many of them, of my patients, from the blood test, I can see that they are slightly anemic. They are not exercising well. The good thing is not many are really smoking and taking alcohol, at least at this point of their life. Now, lastly, right, please do ask our patients, okay, what matters most to them. And in fact, don't be afraid, finally, to make sure that as we take care of our patients, we want to make sure that they are sent off well. There's nothing wrong to ask our patients regarding how they plan for their last day, to spend their last day, advanced care planning, so that they go with dignity and autonomy. Now, this is overall the holistic lens that I think we should be tackling in our patients. So I want to now bring all of us back to the context of a clinics now, okay? May it be face-to-face or through virtual care. How do we approach a patient who come and see us, or a patient in their 40s who grappling with the context of getting old, or an elderly. Now, 1 in 4, 1 in 5 of our patients that we see in our clinic now is an elderly. That's why I say the way that we consult and see a patient should change. It should be no longer, how is your blood pressure? It should be no longer, are you seeing me for your cough and cold? They may be coming with all these presenting complaints. I think the most meaningful is what matters most to them. What matters most to them at this juncture of their life. That's the first thing. Now, all of us are different. Every of our patients are different, okay? In fact, what is important to one elderly may be very different from another elderly. So we have to ask the patient what matters most to them. Some elderly love to be highly mobile. They love outgoing. They live an outgoing, active lifestyle. Some elderly love to be with families. Some elderly may be an introvert. Therefore, it is very important to assess them in the context of what matters most to them. In the clinics, right, I've set in place a lot of systems. We have to measure their capability, not just their blood pressure, their sugar, their medical problem. We should measure their functional status. How many of your elderly come and visit you on a wheelchair, on a walking stick? How many of them can get up from sitting on a chair without help or without having, it is a privilege, and many of us take it for granted. I sit on the chair, I can stand up by myself. Many of the elderly, if you cast your eye across in the hawker centers, shopping mall, they have to press their hand, put their hand onto the table, press it to lift themselves up. You can see that this is deterioration in function. Cognition, memory, and a lot of times we have forgotten, okay? We have forgotten to measure not just their nutritional status, their functional status, their cognition, their mood. We have forgotten the continent. How many of us ever ask our elderly patient, are you able to pass urine well at night? How many times can you wake up at night? How many times do you have to wake up at night to pee, to pass urine? You'll be shocked. Many are traumatized because they literally don't have a good sleep. They have to wake up almost every 1 hourly or 2 hourly. In fact, I lost a patient many years back, more than 10 years ago, because he literally is so traumatized that he has to wake up passing urine every night per hourly. And a few months later, he couldn't cope with it. He actually jumped down from, I think, the 9th floor and he died at the age of 76 or 79. Now, this is something that has struck me for a long, long time. Simple things that we can do at ease actually become something, a huge burden to the elderly, you see. Now, having asked what matters most to them, a simple setup in the clinic that you can do all this functional assessment without the doctors involved. The functional assessments can be easily done. That's why I share you what I normally do to the patient. Without us spending a lot of time in terms of measure. At the end, after we do that, we have to come to a reconciliation. Looking at the patient medical problem, looking at what matters most to them, looking at the holistic lens of how we assess them, we reconcile this. We treat what is most important to the patient. In an elderly patient, we can't treat everything. Medicine, polypharmacy has to be reduced to the minimum. And in fact, a lot of times, we have to look at the expense of the quality of life versus how much we should treat the patients, okay? And finally, is to come down together with the patient, share with them our common goal, refer mainly to the family, to the society, to the community for support. Definitely, we can't do everything ourselves, okay? Now, there are many tools, okay, that we can make use of. In this day and age, there are many AI tools that help us to do GATE, memory score. Now, there are many simple apps that the patient can use for us to do mental tests, depression score, nutritional screen. without us having to actively participate in this. Okay. Now, this is something that is very important. As the patient comes in, right, when we assess their body, mind, function, medicine, and support, this collectively, right, will help us to form a framework. Now, as a primary care physician, right, many of us will say, oh, this is so daunting. I have to spend time doing all these things. No. Remember, patients come and see us for continued care. They are not episodic when they fall sick. A lot of these elderly patients follow us for monthly follow-up with chronic disease. A lot of this can be assessed across different visits. In fact, it can be done very easily once we master it, okay? You see, blood pressures, lipids, all this, we do it once every few months when they come and visit us. BP can be taken by your staff. Control of lipids and cholesterol and sugar can be done by blood tests every 4 months, 6 months, or yearly. Mental assessment is how we interact with our patients. What method to use most? How are you feeling today? How are you coping with life? Function. We can stay at our eye the moment the patient walks into our room. Can the patient move freely? Are they moving with aids? Do they need help to sit down? At one glance, this doesn't take much effort, but it takes an active glance. We need to really think through that and become part of our consultation process, you see. And then in terms of medicine, as we give out, we have to ask ourselves, do the patient need this so many medicine? What are the medicine that I can cut down? What are the dosages that I can reduce? It is very important, not just polypharmacy, reduction in the dosage as elderly. And a lot of the elderly also have compromised renal function. Now, it is very important. In fact, many of our elderlies, right, suffer from over-prescription. Not only that, unnecessary prescription. So de-prescribing is something that, as a doctor, we have to actively put our effort in. Then lastly, before the patient leaves our room, always ask ourselves, does this patient need any additional support in terms of a caregiver, in terms of even finances, in terms of home safety? Therefore, right, it is imperative, right, when every patient leaves our room. Now, those of you who are my students before, who has gone through my clinics and all this, in the acute cases, I always tell my students this, or even fellow doctors who are trained by me. Before a patient will come and leave our room, we should ask ourselves a few questions. This is for acute case. Does the patient know what is the diagnosis? Does the patient know how long he takes to recover from this flu, cough, and cold? Does the patient know that what happens if he doesn't get better? These 3 questions must be answered before the patient leaves your room. For an elderly, we have to ask ourselves, the moment this elderly patient leaves my consultation room or finish a teleconsultation with me, I have to ask myself these few questions. This patient is leaving me now. Okay, after I've assessed him, is he going to be safe at home for the next 1 month? Is he able to move around by himself or herself? Who are the family who is going to take care of these patients? And nutritionally, in terms of safety, who will be there? We have to satisfy ourselves that this patient leave my room, he will remain safe at home. Now, as a doctor, right, the last we want to find out is 1 month later, patient number come back, and we find out our patient has collapsed at home for 3 to 5 days and nobody has found her. In my years of practice, I've lost a few patients like that. And the patient collapsed at home for 3 to 4 days, nobody discovered it. Few days later, the doctor comes and said me, I found out my mom collapsed and died at home, passed away at home. And nobody discovered because the children don't visit the parents every day. And the parents are alone by themselves. Now, a lot of this actually glimpse from the fact that the patient must be, we have failed our patients, okay? If the patient collects at home for more than a day and nobody found out, there must be some system that this patient is connected to somebody, and if there's no such active connection in the last 24 hours, somebody better go to the house. Then I think we've done something at least for our patient to make sure that when they go nicely. Okay. Now, in this age of AI technology, this should be history. Okay, I'll share with you later. Now, I go back now to share something on as a doctor now. Okay, in the context of an aging population, our aims when we see a 30, 40, or 50 years old now is we want to make sure that our patient, by the time they are 70, 80, they have more years of independent and meaningful life. Okay, so it is very important as a primary care physician that primary prevention is our cornerstone. I'm extremely thankful that in Singapore context we are fortunate that the Ministry of Health and a lot of GPs has participated in OtterSG. That sort of bring us into the attention of primary prevention in terms of vaccination, timely vaccination for pneumococcal flu vaccine, smoking cessation intervention. Now, more should be done in the context of nutritional, physical activities, oral health, okay, which we have forgotten. Now, oral health is so important that a lot of elderly have poor nutrition, not because they can't afford the food, they don't have the teeth, they don't have the strength to bite, to eat. And that's very important. Their sleep, their social life. It is time to start at 30, 40 to make sure that by the time our patient is 65, 70, 80, fine. Now, what to do now in the context of an aging population? Unfortunately, 1 in 4 of our patients by 2030 is going to be already old. They will pass primary prevention. Many of them has already fallen sick, okay? Now, it is not too late. For a group like this, secondary prevention must come in, okay? Now, to me, it's very important. When secondary prevention comes in is we must tailor to the patient needs, to what matter most to the patients. You see, many of us who are doctors, we must be realistic. Patients at 70 years old, okay, maybe with compromised renal function, we know that if the renal function will still go on for another 10 good years, there's no point to insist that the patient must have tip-top HbA1c control and tell them anything also cannot eat so well. We want to balance between the quality of life and the length of remaining life. I think that's very important. Okay. Patient is not a statistic. It is even more important to give them good, meaningful life, although they can live shorter life. I would look at that as a context. Okay. Now, of course, finally, for patients who has already fall down, broken their bone, stroke, tertiary prevention comes in. We want to make sure that as far as possible, the rehabilitation, the family support all kick in, so that any disability, any complication is being minimized, giving the caregiver the maximum support. Now, I want to highlight again, measure what matters, okay? To the elderly, mobility, able to move by themselves is important versus lying on the bed doing nothing, having to rely on people to change their diaper to clean themselves up, okay? Instilling a sense of confidence that they can manage their own life is vital. And it is very important to give meanings to their life. Now, the other thing that I want to share is this. Now I move to certain disease now, okay? Firstly, many of our patients who have chronic disease, diabetes, high blood pressure, hypertension, bear in mind, I'll share with you, it is no longer chronic disease 3. As a doctors, many of us has forgotten it's no longer 3 chronic disease. Actually, it's 3 plus 1. How many of your patients is usually obese and overweight? It is not the burden of that 3 disease. In fact, I tell most of my patients now you have 4 disease, 4 high. You know, in Singapore, they used to say 三高, 3 things that's very high. Your blood pressure is high, your sugar is high, your cholesterol is high. I tell all my patients now your weight is also high. We know that almost 60% of our population is overweight. Don't forget that actually this is a huge burden. In fact, I tell a lot of my patients now, you go and see outside all my chronic patients, okay? Those who has only 3 high or 2 without the weight, okay? Most of them are still highly mobile. Those who are obese and overweight, many of them has functional disability when they're 65, 70. Or any, they are either on wheelchair, they need assistance, they need a helper. It is extremely important not to forget the last high, which is weight. Okay. Now, we have to, in terms of chronic disease management of this, we have to remember this, okay? We have to move from target to trade-off. And this is why I emphasize. Don't be so obsessed that your blood pressure must be below 120/80. Don't be so obsessed that the HbA1c must be below 7%. Their cholesterol must be 130. They have already lived 65 years, 70 good years. Many of us may not live that long even compared to them, okay? We want to make sure that they have good quality of life, okay? So there must be some trade-off. Prioritize the condition that threaten function, comfort, or independence most. In fact, if you ask me whether should I prioritize a patient diabetes control at 70, a patient of 70 years old, I must make sure his diabetes control is less than 6.5, or I make sure that he can walk better, he is fully independent, he has good muscle bone. I will tell you that I want him to be functionally independent and having a HbA1c of 8. I think that's very important, okay? That kind of trade-off is what we come to make sure that our patient live happily, independently, okay? And don't be so obsessed with certain biochemical marker. Now, the other thing is it has to be individualized target, okay? Based on variety, life expectancy, and patient goal. Look, if the patient life expectancy is having renal failure now, on dialysis 3 times a week, then we know that patient has another 5 or 10 good years. Do you want to tell the patient that, look, you cannot eat this, eat that, everything must be very careful, you cannot do this, do that? No. I think ultimately we want to make sure that despite what they have, we want to make sure that they have good life, the good remaining life. Okay. Now it is also very important. Do we want to ask a patient who is 75, 80 years old, okay, who doesn't need to run a marathon, okay, who has ONE to undergo surgical stress or operation, if what they want is to go from their house, walk 200 meters to the supermarket and come home. The trade-off must be that if the knee, despite the severity of the ONE, but they can still functionally walk 200 meters and come back without much disability. Do we want them to go for the risk of surgical correction, facing the possibility of complication? That's assuming that the diabetic is not well controlled. So there must be a balance between the trade-off of what kind of lifestyle this patient has. So I always prioritize that in the context of these patients, you see. So I want to make sure that patient at 80 years old, they can walk 200 meters. They don't have to go and expose themselves to the risk of unnecessary surgical intervention. You can't make them to become a robot, you know. Now, the other thing that's very important is every elderly that comes to our clinic, de-prescribed drug, okay, without much benefit. Now, how many of them, for example, okay, are given unnecessary medication just to control them so tightly that we want their pressure to be tip-top, okay? How many of them do not need unnecessary supplement? how many of them do not need unnecessary polypharmacy? Now, it is very important. Do they need 4 drugs to control their diabetes to bring them below 6, or they need 2 drugs to keep their HbA1c of 7.5? We have to ask ourselves all these important questions. And it is also very important, okay? We want to simplify the dosing. As one get older, you cannot give them a TDS medicine. You cannot take their diabetic medicine that take twice a day when you have the option to give them a medication that is to be taken once a day. When you have the option to give them combination pills. Now, why do we need to prescribe, okay, ACE inhibitor with amlodipine calcium antagonist when you have combination pill to an elderly that takes 2 medicine rather than 1? The trade-off is always to find a replacement that gives them lesser and less medicine. In my years of practice, right, the first thing is when the patient comes and see me with 50 medicine, my aim is to make sure that I can cut down them to 5 medicine. And that's very important. The diabetic medicine can be a combination pill of 2 medicine, Gavasmac with metformin. But how many of time we see that the patient is given lipidide plus metformin separately? Now you can imagine when we turn 70, we'll have problems scrambling for pills and popping different type of medicine, trying to recall that. I hope all of us can start to look at this critically, okay? In fact, I always tell myself and tell the patient, look, the moment you come and see me, you have 7 or 8 medicine, I'm going to change it to 3 to 4 as far as possible, okay? Now, the other thing is this, okay? It is also very important. A lot of time when patient is in the hospitals, right, when they are discharged, right, there are a few things that can happen. Either they are being put on more drugs, or certain drugs that they're all they've been taken off. It is very important for us to review again whether they need the drugs. Okay, for example, a lot of antihypertensive drug has been taken off when the patient is hospital resting down. We have to be realistic. This patient, when they are discharged from hospital to home care, they may be living in a house with high stress. Their BP is always very high. So the environment has changed. Antihypertensives have to be put back. And not only that, a lot of patients being discharged, a lot of times from multiple specialists, okay? They can be on anticoagulant that is of double the dosage. The neurologist give one anticoagulant, the cardiologist give another anticoagulant, and nobody is looking at it. And when you ask and you look at the patient, please by all means take off one of the anticoagulants. Therefore, this is very important. I always tell my patients when they come out from the hospital, please bring me all the medicine in front of me. I want to look at all your medicine now. They bring me the whole bag, Now, so this is what I touch on chronic disease, okay? Now, in terms of 4 priority, now I want to shift to other aspect of the elderly care now, cognitive decline, okay? It is very important, okay? Patients, as they grow older, a lot of them start to lose weight. We have to ask ourselves, they become very weak, very slow, okay? Are they eating well? And just now I mentioned, please look into their mouth. How many of us actually look into our patient dentition? How many of us actually look at their teeth, How do we expect an elderly to eat well when he can't even chew properly, okay? How many of us actually tell our elderly, please go and see a dentist for your teeth when they look so frail? We always tell them, hey, eat more, eat more. But that's not a matter of eating more. They can't eat more. They can't even chew. Okay, how many of us actually assess the patients in terms of whether they can fall or not? Now, when a patient fall, right, it is not just weakness, okay? Many of the time they can't even see clearly. How many of us has actually asked ourselves and look at the patient eye whether they have cataracts or not, whether their vision is failing, okay? It is very important. How many of us actually look at the feet of our patient to see why they fall? What kind of shoes are they wearing, What kind of arthritis are they having now that they couldn't walk properly? Now, many of us has forgotten all this. Okay. Now, the last thing is this. Many of our patients, I start to realize that the relative will come and tell me, hey, there's something wrong with the memory, sometimes they cannot remember this and that. Just ask ourselves, okay, in the last 20 years, how many of us have screened our elderly for their cognition? Have you done an MRI to screen whether they have early dementia? Have you do a memory score test for, when was the last time we do a memory score test for a patient that's 65 and above? Okay. When was the last time we asked their families, their carers, or the helper who comes in and said, does he remember things well or not? Or do we wait for our patient to tell us, for the relative to tell us, hey, I think this so and so gentleman seems to be very forgetful now, you see? So what I'm trying to say here is a lot of these have to be active. We, as a doctors, as our patients, confidently, we cannot wait for them to tell us. That's too late, okay? So our mindset must change, Our mindset must change from treating the disease to actually looking at functional decline as a vital sign. This is not normal aging, okay? We have elderly who can climb a tree, okay? Who can climb a tree at 90 years old, who can run a marathon at 100. Are you trying to say that our elderly who are 70 who need a walking stick, that is not normal aging, okay? Now, the other part which I want to emphasize a lot is this, okay? A lot of our elderly, please assess their mental health, okay? Many elderly live in anxiety and fear. Now, one of the things that I've observed is as one get older, a lot of my confident young patients in their 40, 50, they think they can conquer the world. As they age, right, they start to live in trepidation and anxiety. It's very unusual. They start to become like a baby, they start to be very uncertain of the world. As they grow older, they know that they are towards the end of their life. They start to be worried how they're going to die. They start to feel a bit depressed. And many of them are actually lonely. And in fact, many of them also worry about their finances and all these things. So it is very important to always ask who are the carers. Are they living alone by themselves? Okay. And we want to plan that in advance. Talk to their children and families. I think that's important. So it is important to ask this question. When you need help, who is there to help you? You'll be shocked to find that many of them are actually living alone. Okay. So it is very important to actually look at all these things as important as the way we look at blood pressure and HbA1c. Now, of course, as we move out from the patient's angle, right, we move to the society now. We have to look beyond our clinic, okay, beyond our virtual care. Please try to think about roping in their families, whether eventually there's home care, be familiarized with the community service, primary care team, who is the pharmacist and the hospitals that can exist in this whole ecosystem. Now, for this practical model, right, for holistic primary care, it is very important, okay? So I just want to recap now. I'm nearing the end of my talk. It is very important to ask what matters most to the patient. Actively screen for function, variety for mood, cognition, okay? Prioritize especially prevention before something set in, and independent. Try not to think too much of disease target, okay? It is important, okay? But I think there must be some trade-off here, and ultimately expand beyond the clinic to see, especially the home, the society, the community, what can be built in. And at every visit, must review the disease burden, okay? Our goal is to help so that our elderly live safely, meaningfully, and independently for as long as possible. Now, I want to touch briefly on my next few slides, right? Okay. We are privileged in these days of AI. I love AI, okay? I like to share AI. So in the context of the care of the elderly, we can't do a lot of things by ourselves. Hopefully this day is
Clinic's command center, the Q dashboard.
Okay. Hopefully this day is behind us, because what is very important is we can actually use AI to do a lot of triaging before the patient visit to capture a lot of things. Now, there are many tools that we can make use of. We should try to do that, okay? It is important, okay, during visit. And it is also important that where AI actually matter most is before visit we can use, during visit we can also use that. And it is also very important to actually look at after visit, there must be some K-plane or this thing that can be generated by AI, okay? And in between visit, a lot of reminder trigger can be done by AI. And that's actually very unique. Eamon, can you see my screen or not, Eamon? Okay, so the AI enable look care, it is actually very important. We can use AI to capture all the necessary symptoms. AI can help us to interpret, to plan for the goal, to act on this. Now, patients can have a patient companion in the form of AI, which as a company we are developing now. Patient companion can help us to do many jobs for the elderly as they age. It can talk to the patient, provide support, reminder in the context of their own languages. The doctors can have an AI to remind us what matters most. Okay, the AI can summarize, flag to us what we need to look at for these patients, especially in the context of the elderly. Now, the AI can play the roles of care coordinators, linking up with all the necessary community support, referrals, and missed follow-up. Now, we hope with the implementation of all these, right, AI-enabled tools, the way that we can take care of elderly becomes so simple because AI will take care of the pre-consult, in-between consult, and post-consult. And patient will have a companion that accompany them as they age. And the doctors will have AI that help us to track the progress of our patients, you see. Now, there are a lot of high-impact AI use cases already in aging care. The AI can help us to check for the duplicate treatment medicine, flag to us that this patient seems to be on 2 similar drugs, okay? And flag to us that this patient is taking too many drugs. Is this necessary? So it makes our life easier. The AI can also help us to support cognitive function. You know, the AI companion can actually talk to the patient, play their games. Now, in fact, there is actually a company that create this game for the patient to play with dementia to play, you know, and it's come from Singapore. And AI in the future can actually help to reduce the burden. Imagine an AI companion talking to the patient, discussing with them, chit-chatting with them. These are things that as a doctor, we can't do it ourselves, okay? Now, AI can also help in terms of prompting the phone. Now, in Singapore, there's actually a devices where we are actually putting a lot of HDB flag now. And this devices is very unique. It can pick up a phone in the patient, activate a control center, and AI can also use to actually improve the patient participation and their physical activity exercise at home. So reminder, morning exercise, evening exercise, you see. So these are things that as a doctor, we should try to use all these AI use cases already in actively managing our patients. Okay, remind the patient to take their blood pressure, their medicine. Now, it is also very important, okay, ultimately, everyone has to go, okay? End of life planning is very important in terms of how we talk to our patient, how to make sure that we not only take care of them, we also send them off nicely. Now, this is my last slide, okay? I want to share this very clearly and simply. And this actually conceptualize on the fact that how I look at my patients when they come to my clinics, okay? So for every patient that comes to my clinics now, right, the first thing I'll look at them is the meanings of life, okay? What it matter most importance to them. So if you can see that, right, at a quick glance, I will actually see the 3M in their head as I look at them. How's your mood today? Are they happy? Do they seem to have any cognitive deterioration? How's the memory? And how do they look at the meaning of life? Are they depressed? Are they very excited? So I must have a good grasp of this when I look at a patient on the head, okay? It's very important. Now, the other thing is, I'll flip to the fact that this patient comes from diabetes, cholesterol, hypertension. As I say that, most of us only emphasize on these three. It is 3 plus 1. Remember that weight is so critical and important. And this 3 plus 1 is something that we must not forget. It is the plus 1 that actually is crucial. Now, the other thing that is, I will flip to the other side now. I will ask my patient to do a few things. I will always look at their bone. I will move their joint to see that whether there's crepitus, there's deformity of the joint. And in fact, I ask every of my patients who are past 60s, right? I say, can you sit on a chair now? Stand up with one leg standing and the other leg. This is to assess their muscle strength for sarcopenia. Now, it is very important. How many of us actually screen our patient for sarcopenia? So I use the mnemonic BMJ. It's not a British Medical Journal, okay? You look for the bone, the muscle, and the joint. And the muscle sarcopenia is an increasingly huge problem in our elderly. Okay. Now, the other part is this. Many of us has forgotten sexual health and continence. Okay, as I mentioned just now, this is something extremely important. I have many elderly, okay, who are in their 70 plus, okay, who come for sexual enhancing drug, okay, whether they have girlfriend, their wife, or spouses. Now, doesn't mean that an elderly patient in their 65, 70, 75 has no such needs. It is important to preach this topic because it is part of the holistic care of a patient. And it is even more important to look at continence, okay? As I mentioned that many of them have to wake up almost nightly and it actually affects their sleep. And that is actually crucial. Now, at the end of the day, when I look at the two food, right, we have to ask ourselves, do they have good family support? Do they have good community support? Now, it is not difficult, okay? In a glance of less than 5 minutes, okay? The more we do this, the more we assess our patient correctly in the clinics, you see. Now, it is very important. That's why you notice that, right? When patients come in, greet them. You can develop a system of your own, Hello, Mr. Tan. How are you today? Do you remember what day is today? A very simple question. Oh, it's a very good morning, And then, how was your sleep last night? Then you can assess the mood already, the memory already, the meaning. This is just by one question. Then the next minute is you look at the blood pressure, everything that you have checked. Actively discuss about their weight because 60% will have weight that is out of the norm, okay? The BMI has exceeded. And the next minute, as they sit down, test their reflexes, look at their joint, their muscle, ask them to stand up using one leg, assess for sarcopenia. Now, at the end of the day, before they leave, after they chit-chat with you, talk about everything, right? Ask them, do you pass your urine well at night? Okay. How is your sexual life? You will be amazed. This is covered in less than 5 minutes. There's one thing that I always look in all the patients that comes to my clinics is I always look at their eyes, okay? I always shine torch into their eye. Every single patient. The thing is, I want to make sure that they can see clearly. There's no deterioration in eyesight that affect their function, okay, in life and the quality of life. And finally, before they leave the room, right, always look at it. Who come with them? Are they waiting outside, or are they coming alone or not? You see? And our aim is to make sure that there's somebody at home or somebody that they can connect to that can take care of them, you know? And that's very important. So I leave you all with this slide to think through. Of course, you can come up with your own, but essentially, the way that I'm trying to say is conventionally, the way we see patient now is no longer, okay, please sit down. Your diabetic is very good. Your pressure is very good. And we forget about all the rest. The approach is always function must take precedence. Mental health, their moods, their lifestyle, their independence must surely be the major marker of how well our elderly age. Now, I just want to share with you one thing that I observed in China. Okay, recently I've come back from China. It is very interesting that in a lot of clinics in China now, okay, they have moved into healthy living, healthy care. So clinics no longer treat patients for their chronic diseases. They want to make sure that their elderly, their patients actually age well. So a lot of clinics actually set up health center, not just for screening, okay? Exercise center. So now instead of patient coming to see us at 8 o'clock in the morning to check for their diabetes or this thing, you see that patient gather in the clinic next door, which is another clinic, to participate in group exercise in the morning at 8 o'clock, maybe afternoon another session, exercise program, nutritional program. So it's very amazing, you see. This thing has shift of how a clinic has evolved from actually treating disease and illness now to healthy living in terms of nutrition, prevention screening, exercise regime. So you can see that it is very important that we compartmentalize, even in the context of Singapore, right? A small clinics are a part of our small clinic to emphasize that there's an educational corner on this. Even we might not have the space, like in China, to set up a exercise center beside our clinics, or exercise clinic with all the fixed program, cooking program, and all this to make sure that our patient is taken care of. At least we have a corner in our clinic that teach the patient about healthy eating, healthy exercise, healthy living. So when the patient leaves the clinic, at least in this clinic with the mindset that this is very important, because the doctor actually tell me that I want to age healthily, you see. Oh, at least we refer them to the community programs. In Singapore, we should send them out to participate in the communities, the CC program for exercising, cookings, and all these things. Get our patient actively involved in this. What I'm trying to say is, in elderly patient managing them, we should think more of social prescription, not just medical prescription. Okay? Yeah, I think I'll end my talk here. So Alfred, thanks for listening. Yeah.
Right. Thank you, Dr. Siaw. So we will be sharing the attendance form later. So any questions you all can put into the attendance form. Then after that, I will get Dr. Siaw to come back and answer, right? Okay. So before our second speaker, we will go for a short break, a quick 3-minute break, right? So yeah, during this break, I will play a video. Then after that, we will invite our second speaker up on stage. Okay. Thank you, Dr. Siaw.
Yeah, thanks.
Structured, visible, and updated live, so your team stays coordinated at all times. Track every patient in real time, from waiting to consultation to completion. Instantly see who's being attended, which doctor is assigned, and which room they're in. Register new patients quickly with a clean and structured form. Capture essential details, from personal information to contact and address, all in one place. Built for accuracy, speed, and compliance from the very first step. This is where everything comes together, the consultation page. Doctors get a complete view of the patient, including medical history, allergies, and ongoing conditions. Document clinical notes, manage the current visit, and access past records, all without switching screens. Lab results, corporate coverage, and billing details are fully integrated into the workflow. Everything is designed to reduce clicks, save time, and let doctors focus on what matters most, the patient. Manage your clinic schedule with a clear and flexible calendar view. Easily track appointments by doctor time and visit type. All in one place. Switch between day, week, or monthly views to plan ahead with clarity. Everything stays organized so your clinic runs smoothly without scheduling conflicts. Manage corporate patients and panel schemes with full visibility. Track company accounts, billing arrangements, and coverage details in one place. Ensure accurate claims, reduce manual errors, and maintain clear financial control. Everything is structured to support growing clinic operations and corporate partnerships. Get full visibility of your clinic's financials in one place. Track invoices, payments, and outstanding balances with clarity. Every transaction is recorded and organized, so nothing is missed. Simple, transparent, and built for better financial control. Manage your clinic's inventory with accuracy and control. Track medicines, stock levels, and pricing in a structured system. Easily monitor availability and ensure your clinic is always prepared. Everything is organized to support smooth daily operations. Access patient lab results directly within the system. View test results clearly, with all records linked to the patient's profile. No need to switch platforms or search through external reports. Everything is integrated to support faster and more informed clinical decisions. OtterSG CMS, built for real clinics, real workflows. Simple, powerful, ready to scale. Scan the QR code to get started or contact us today.
All right, so welcome back, everyone. Our next speaker for tonight is Dr. Pinakin. So Dr. Pinakin is a UK fellowship-trained cardiologist based in Singapore with expertise in both preventive and interventional cardiology. He completed his medical degree at the National University of Singapore and underwent cardiology residency training at the National Heart Centre, Singapore. Before further advanced in intervention cardiology training at the Liverpool Heart and Chest Hospital in the UK. He is actively involved in the management of cardiovascular risk factors including hypertension, diabetes, cholesterol disorder, and obesity, while also handling complex interventional cardiac procedures such as angioplastics, calcified lesions, and chronic total occlusions. Beyond clinical work, Dr. Pinakin is deeply involved in medical education and regularly contributes to regional and international cardiologist conferences. He also teaches at both the Yong Lu Ling School of Medicine and Lee Gong Chiang School of Medicine. Tonight, he will be speaking on calcification, clarification, a primary care guide to CT-based cardiac imaging in coronary artery diseases. Right. So please join me in welcoming Dr. Pinakin. Hi.
Okay, hi everyone. Thank you, Alfred, for having me. My name is Dr. Pinakin. I'm a cardiologist based in Singapore. I'm a general and preventive cardiologist, and my subspecialty interest is that in interventional cardiology. And I can't help but smile at Dr. Siaw's last stick drawing of how he approaches patients, and he had a very strong emphasis with regards to 3+1. Remember, we talk about high blood and cholesterol and diabetes, but don't forget obesity as a cardiovascular risk factor. So I think today I wanted to give a talk which is not your usual flavor. Before that, I just want to check. Alfred, can you hear me clearly on your end? Because I want to make sure the audience hears me very nicely.
Yes, Dr. Pinakin, everything is loud and clear.
Okay. Okay, so this is a special topic because you must realize in primary care now that cardiac care has changed. The landscape has changed, and now a lot of people are recognizing the power of CT calcium score and CT coronary angiogram. Using treadmills, using simple treadmills as a way to determine whether someone has any coronary artery disease or whether someone has ischemic heart disease is not as powerful anymore. And with so many x-ray centers, especially in Singapore, offering such services, I think the primary care physician should have some awareness. So if you look at the title, I've very creatively made a word play. So it's called calcification clarification. And I think what I want to achieve in the next half an hour or so is the following next few points. Let's see. I can't seem to advance my slides. Okay, can. Okay, good. So here we go. So I think the 6 questions that I want to answer and make all of you all understand is number 1, what is CT calcification? Where does it happen in the coronary artery? And why does it happen? Okay, so I think you need to be aware of that. Is it because the patient takes so much of calcium supplementation? I get this question asked a lot. Number 2, beyond CT calcium score, if you do a CT coronary angiogram, what added information do you get? And number 3, does a low CT calcium score, so your calcium score is very low on the CT scan, does it mean that you have no blockage? Does it mean you have no plaque? Also, I think you need to realize when is CT imaging not reliable. So I'll answer all these questions as we go along. And once you can work through 1, 2, and 3, how do you use the calcium scores and plus minus CT coronary angiogram to decide when to start statins for a patient? Because there's some patients who are on the fickle-minded. You as a GP offer them cholesterol medications, then they say, doctor, let me try for another 3 more months, let me try for 6 more months, and then they come back to you, the values are still high. Sometimes you might need to do a certain test to make them believe that they need to start statins because something is going on. And finally, because I'm an interventional cardiologist, I think it's useful to know why calcium in your heart can be a problem for doctors like me who deal with blockages and open up coronary arteries. Okay, so question number 1, I need all of you all to unfortunately go back to medical school, and this is a diagram of the vessel. Okay, so this is a vessel, and you can take it to be a coronary artery. There are 3 layers. Remember the tunica intima, the single cell innermost layer. There is the tunica media, which is the sandwich layer of muscle cells. And then you have tunica adventitial, which is the fibrous tissue. All right, so this is how the structure is. But you also realize that there's LDL, low density lipoprotein, which is in the bloodstream. So this is the vessel wall. Hope you can see my laser. But the LDL gets ingested into the vessel. You have monocytes, your white cells, which then get also ingested through receptors. The LDL interact with the monocytes and they become macrophages, foam cells, and then they lead to a cascade of inflammation within the vessel wall. Okay, lead to inflammation. And once there's inflammation in your intima, the single most layer, your muscles in your artery, the second layer, also go and interact and cause a plaque formation, inside the wall. And as the plaque gets bigger and bigger, it can go and encroach into the lumen because there's not so much space for the vessels to dilate to accommodate the plaque. and then it just has a narrowing inside your vessels. Okay, and then as the inflammation happens, you can have calcium deposition inside the vessel wall. All right, so all this plaque and the calcium is within the walls, but as the plaque gets more and more, there's no space to dilate outwards, there's going to be luminal narrowing of the passageway. So calcium, if you just think of calcium score, they are only looking at the walls and looking for this hardening of your arteries. Okay. Let me just see whether my slides have hung. Alfred, are you able to go forward on my slides?
Let me try.
Yeah.
No, I'm not able to do that as well.
No, yeah.
Can
Okay,
can,
let
can you
me
try
see.
to like maybe restart it?
Okay, let me try. Yeah. So stop sharing 1 second. Thing hung, huh? Okay, I'm getting back there. Sorry, guys, for eagerly listening. Share screen, share screen. Okay, are you able to see now?
Right? Yes, it's up already.
Yes. Okay, we are back up. Okay, so okay, so I think that's where we at now. So about calcium. So let me show you how a CT calcium score imaging looks like. Okay, so this is a CT scan of the heart, and a CT calcium score is a very basic scan that you do not need any dye that needs to be injected into your heart, into your veins. The patient goes inside, and what it tries to do, it uses a counter to kind of count the calcium which is deposited into the walls of your arteries. So here I'm just showing you the coronary artery with no calcium in the walls, and you can see in another patient there's a lot of heavy duty white material in the walls of the artery, which is calcium. And we know if there is calcium in your artery walls, then there has to be some plaque and some inflammation which has led to the deposition of calcium. Okay, so this is a calcium score, and when we score calcium, remember there's no dye involved, it's only looking at the outer wall. We have a score of 0, 1 to 100, 100 to 300, and more than 300. And we know from a lot of data, the higher the calcium score, the greater the risk of you having a heart attack or stroke in the next 10 years. And the higher the calcium score, the greater the burden of coronary artery disease, and the greater the chance of you have narrowing inside the passageway to cause ischemic heart disease. Right? So if you have a calcium score of 0, you are good, but as you go higher, then you should be a little bit more wary about these patients and decide whether they need medications to bring down the cholesterol even more, and even whether they should be getting some form of stress test or ischemic heart evaluation. And how do you evaluate for ischemic heart disease? Of course, you can do your stress test, but these days we can do a CT coronary angiogram. So it's like doing an angiogram invasively, but delineating your coronary arteries from outside the body beyond just a simple calcium score which has no dye involved. So I'm just going to show you some guidelines from the world what to do with regards to calcium score. So, if you have a high calcium score in a patient who is otherwise asymptomatic, but the calcium score is more than 100, it is reasonable to start statins for them. All right. So if your calcium score is 0, you're quite safe. But if you have someone with high cholesterol and the calcium score, which is more than 100, there's some burden of disease, of plaque. And even if you don't have a CT coronary angiogram, you can consider starting statins. But there's a latest guidelines released recently this year, which I'll show you in a while, which says that even if you have a calcium score of 1, even if you have a calcium score of 1, you can consider starting statins because there's already some deposition which is not supposed to be there. Okay, so now question 2, what is a CT coronary angiogram? And this is an example of one of my patients. So remember, the calcium score only looks at the walls. A CT coronary angiogram is when you give contrast, and the contrast goes from your veins into the heart, and the correct time they do a scan, and you get pictures of your arteries like that. So you're able to see not only the wall and calcium in the walls, but the lumen. It's like your house pipes, the drainage. You do not want any blockage inside. So for example, this is the LED. You can see the smooth flow of the artery, and yes, you can see a small white speck on the wall here, which is the calcium, but the flow is good. There's no obstruction inside. So I think I'm just going to take a pause here to try to conceptualize something. So a CT calcium score is going to help you in primary prevention. So you've got a patient who's got high cholesterol and he doesn't want to take medications and he's trying, and you are trying to convince him. Doing a calcium score will help you decide for him and tell him, hey, there's something already going on in your coronary arteries. You need to really take medications to bring it down because you're trying and nothing is happening. That's a calcium score. A CT coronary angiogram is not so much a risk stratification tool, but rather is an investigation for chest pain. So you've got someone who now not only has high cholesterol, but has symptoms, breathlessness on exertion, angina equivalent, or chest pain on exertion, then you can add on a CT coronary angiogram by putting the dye to kind of look for blockages. All right, so that's the big picture. And unfortunately, in my practice, I see patients who have blockages in the heart, but they have no chest pain. Right? This is the silent disease, the silent coronary artery disease, sometimes seen in female patients, or sometimes even seen in males who have serious blockages, but they have this thing called ischemic conditioning. So they get to live with their blockages, the heart reacts. So sometimes, even for asymptomatic patients, we don't only just stop at a calcium score. It is worthwhile to even ask them whether they want to get the dye, to get a CT coronary angiogram, to not only look at the walls, but also look at the degree of stenosis inside. Because sometimes you can have blockages in the heart, plaques narrowing, with the calcium score being almost 0. And we call this a soft plaque. That means the plaque, the cholesterol inflammation, has not had sufficient time to cause calcification. And if you just rely on calcium score and you tell that patient, oh, calcium score is 0, there's nothing inside your heart, you might miss a soft plaque. And that's why sometimes we can pair up CT calcium with a CT coronary angiogram. Okay, so just to reinforce the point, a calcium score is just to look at plaque burden, is used for asymptomatic screening, especially in someone with cholesterol and you don't know what to do. But if someone has chest pain, you want to look at inside the arteries, you need a CT coronary angiogram. But I will show you in subsequent slides that sometimes even for screening for patients from Indonesia or Philippines who come and see me, they want a thorough screening. I add on a CT coronary angiogram to look at everything, because the CT coronary angiogram also has a calcium score and it's an extended study. Okay, so I think it's always very useful to go through examples, and these are real life examples of mine. So I've got a 73-year-old female retired psychology professor. She's a Filipino and she's staying in Singapore. And her cholesterol is high for the last few years, 160 milligrams per deciliter. If you want to convert to millimoles per deciliter, you divide by 38. All this while, she does not want medications because she's symptom free. Her siblings have bypass and PCI done, and her main symptoms are mainly just tiredness and fatigue on washing the dishes. So she went to a colleague of mine. She's a geriatrician, and the geriatrician decided to do a calcium score only, right? Because the patient did not want to die, and her calcium score came back high. And when we look at calcium scores, we do not compare a calcium score with a 20, 30, 40-year-old person. We look at calcium scores within your age group, a 5-year band, so 70 to 75. And her calcium score was 216, more than 100. So that's quite significant. There's some plaque burden happening. And that puts her at the highest centile for her age group. All right. So she's on the 75th to 90th percentile. That means 90% of people in her age group would have a calcium score lower than her. So what would you do for this patient? Would you just start cholesterol medication to try to bring her LDL down? Or do you also now worry, hang on, is there a narrowing within the lumen of the arteries that's making her fatigue? And I decided, when she saw me, because my colleague had referred to me, I decided to then send her for CT coronary angiogram, convinced her that the dye test is important. We want to look inside, and maybe that's causing her fatigue. Remember, in female patients, they do not present like a textbook case of chest pain. It can be very atypical. So I'm going to show you a CT coronary angiogram. So this is the coronary angiogram where they put a dye. Remember the dye which I showed you in the earlier case? But you look what is happening here. There's no continuity of the white bright dye. There's some disruption here. So there is some flow down to reconstitute the artery, but there's this disruption here with the calcium, very bright speck here. So this patient had a 99% LAD stenosis. Okay, so if you just leave it with a calcium score only, you might not understand what is the true extent, because the calcium score is just percentiles and burden of disease. So this patient then had to go to the angiogram lab. I did an angioplasty for her. So this is the left main. Here, there should be something going down here. If you look at the red color, that's the left anterior descending artery. It is missing because the flow is so slow down, and I had to put in a stent to open up the flow. All right. So the second thing which I want to kind of introduce to the audience when we talk about CT calcium and CT coronary angiogram, even if you go for CT coronary angiogram, so we call it a CT coros, you might see blockages 10%, 20, or even 40 and 50. But just because you see a narrowing inside your coronary arteries, you don't immediately need angioplasty. Back in 20, 30 years ago, a lot of patients were getting stents even for 50% blockage. But now with modern day statins, modern day LDL targets, you don't need to open up blockages, and you only need to consider opening up blockages if on CT scan they are more than 70%. And even then, on CT scan, if the blockages are severe looking, patients would then go and get some form of ischemia demonstration, because if it looks 70% on the CT scan, there's an error of margin, right? So if it's 70%, some people might call it 50%. And I look at all these images, and sometimes it's really borderline. So we only need to bring patients for an angiogram if it's more than 70%, because we want to find out whether there's ischemia, lack of flow down the artery. Yes, you can do a basic treadmill, make them run on a machine with a 70% or 50% blockage to demonstrate ischemia. Treadmill is very, very basic. You can do a enhanced treadmill, which is a stress echo. So instead of just looking at the ECGs, you can do an ultrasound of the heart to look for wall motion changes. But the gold standard now is, if there's some suspicion and some severity of doubt, you can bring them for an angiogram, not to put in a stent, but to do a wire measurement. Okay, so you can put a wire down the coronary artery to measure the flow of the blood across the blockage. So it's percentages. If it's 100% here, the flow after the blockage cannot drop more than 20%. So up to 80% is okay. If it drops to like 60, 70, then there's some value of opening up the artery to prevent a heart attack, because there is ischemia generated. So we call this intracoronary physiology. And you see some interventional cardiologists bringing patients into the lab for blockages, doing measurements, and if it's okay, you don't need to put in a stent. You just need good optimal medical control, which is LDL reduction. And I'll show you a chart of what LDL targets you need to achieve. Okay, and I think this is a small point. Sometimes we see patients, right? They keep coming back to you, doctor, I got chest pain, chest pain, chest pain. They have had a treadmill. Treadmill is normal. They do a CT scan of the heart. The big coronary arteries are normal. The epicardial 3 coronary vessels are normal. But they can still have chest pain, because you must understand the heart is not as simple as this picture in A here. They have the coronary arteries go into the myocardium in a very small, fine network of microcirculation. And some patients do not have a blockage in the macrocirculation. They have this thing called microcirculation dysfunction. And this dysfunction cannot be seen on a CT scan because it's very, very small. The only way to measure this is, again, put a wire down and we can measure the macro and micro circulation. So remember, if your patients keep having pain and they're not getting better, don't label them as a psychiatric issue. They could be having microcirculation dysfunction. And if we measure and find some issues, we can give them some special medications like vasodilators, calcium channel blockers, trimetazidine to improve the microcirculation so that things can flow out into the myocardium very well. Okay, so CT coronary angiogram in such patients who have chest pains, not only to look for blockages. In young patients, I've done CT coronary angiograms even in my pediatric patients, 10-year-old, 12-year-old, because if they keep having pain, sometimes it's anomalous coronary arteries, right? Remember, the coronary arteries come from the aortic root. The ostium are in 2 separate places. Sometimes they are in weird positions and they can be compressed by external structures. A CT coronary angiogram, I think Dr. Siaw spoke about patients who are elderly just now. Sometimes when you do a CT scan of the heart, you get to see the aorta, and if there's a aortic dissection, aortic erosion, you can diagnose them by a CT scan. And remember, the CT scan not only looks at the heart, it also pans left, pans right to look for lung nodules. And in sometimes a CT scan is also useful in patients who have had bypass. Patients who had bypass 10, 20 years ago, they start having pain. You can do a scan to look at the bypass grafts to see whether they are affected or not. So the coronary angiogram has a lot of value to kind of pick up a lot of different things like what I've mentioned. So again, remember, calcium score 0 does not mean no plaque. A CT coronary angiogram can detect an early stage non-calcified lipid soft vulnerable plaque. And by the time you have some calcification, there's some organization of the plaque by calcium deposition. Okay, so just be aware that if the patient is symptomatic, but the calcium score for whatever reason was done in a screening center, just a pure calcium score, you might need to flush and see what's happening inside the lumen. So I give an example here. All right, so this is a 50-year-old female businesswoman. She's a diabetic. She's got cardiovascular risk factors. The diabetes is very well controlled by the endocrinologist at 6.1%, but her LDL is not up to the mark. It's 3 to 4. And she had one episode of chest pain while boarding a plane. She's a businesswoman, very busy, flying all over the world, but she shook off the pain as something not important and just went to see the endocrinologist for a routine check when she came back. And then the endocrinologist called me in for an opinion. Dr. Pinakin, I've got this patient, she's got cardiovascular risk factors, strong diabetic for 10 years. She got some symptoms. What should I do? Should I do a CT calcium or CT coronary angiogram? So by now you have realized if someone is symptomatic, a CT calcium score is more of a risk stratification tool to decide whether she needs statins. But if someone's symptomatic, remember, a calcium score 0 doesn't mean no plaque. I would do a CT coronary angiogram by just putting in a dye. So this is a CT calcium score came back slightly elevated. It's not more than 100. It was only 26. This is the left main. This is the LED. But if you just look at the LED over here at the branch point from the left main, there's a tapering of the start of the LED. So the very, very start of the LED had a severe looking 70% stenosis. I brought her to the lab. This is the angiogram. Left main, remember the bifurcation circumflex. There's a very tight, pinched, focal LED stenosis, and I had to put in a stent from the left main to the LED to open up to prevent this from closing up and from her having a massive heart attack. So remember, CT coronary angiograms help detect serious problems by understanding the lumen. Okay, so I've answered this already, okay? Does a low CT calcium score mean you have no plaque? That is not true. Like the earlier case, you can have something happening inside. So the fourth point is important. When is a CT imaging not reliable? But before that, just to drive in a point, asymptomatic patient, let's say an example, 45-year-old, no symptoms, high cholesterol, calcium score 0, okay, not too bad because the calcium score is 0, his prognosis is not too bad, but remember, you can have soft plaques that you might be missing out. So you can offer him a CT coronary angiogram just to rule out a plaque. But if a same patient is 45-year-old who has chest pain, a calcium score is 0, this is a false reassurance. Remember, soft plaques can still be possible. So when is a CT imaging not reliable? Remember, if you have too much calcium on the walls, typically more than 600, sometimes more than 1,000, and if you still want to send them for CT angiogram, then you might have difficulty interpretation. Because if you have too much calcium on the walls, the CT coronary angiogram, even if you put in a dye, you cannot penetrate inside because of too much calcium. Too much of bright calcium is called a blooming artifact. So sometimes you might realize if you send a patient for CT coronary angiogram, the radiologist might call you and say, because they always do a CT calcium first, oh doctor, the calcium score is too high. do you want us to proceed with the angiogram because the results will be hard to interpret? And then you can technically say no, because if the calcium score is very high, typically more than 600 or 1000, the burden of arteriosclerotic disease is so high, they might need an angiogram to delineate the anatomy. And even if you send them for CT cornea angiogram, you might not be able to see with confidence inside because the radiologist just cannot see. If you already have stents, if you already have metal work, it's very hard to penetrate the metal and you cannot see what's happening inside. So you have to use other strategies. When you send a patient for CT cornea angiogram, if they have atrial fibrillation or they have sinus tachycardia and their heart rate is more than 60 or 65, you won't be able to get good images to reconstruct the cornea arteries and you won't be able to see inside. If the patient, remember when you do a CT scan, the patient needs to hold the breath by 10 to 15 seconds. If they cannot hold their breath to keep the heart still to acquire the images, well, the test might not be for them. Claustrophobia is some patients might have it, but it's not an MRI. It's very fast. The scan only takes about 10 minutes. It's not a tunnel where the head is covered. There's dye that's used. So typically, if your GFR is more than 60, it should not be a deal breaker. Right? You can still give the contrast because the amount of contrast that they use is about 50 to 60 mils only. So I think I just want to use this slide to suggest what are the situations that maybe you don't want to do a CT scan if the calcium score is too high or some of these other factors. But otherwise, it really helps re-stratify patients, even for the asymptomatic one, because low calcium score can miss vulnerable soft plaque. So I give you an example about a place where a CT cornea angiogram did not help the patient. Okay, so this is a 65-year-old American. He's a lawyer. He's very fit, asymptomatic. So a few years ago, 5 years ago, his cholesterol was high. The doctor just did a calcium score. Calcium score was 600 and was started on high intensity statin. 5 years later, he's got a calcium score of 1100 now. But remember, the calcium score is only in the walls. The doctor decided to do a CT cornea angiogram to understand whether there's any choke inside the pipes. And the CT cornea angiogram mentioned the label, the report said the LAD was 90% block. The patient is asymptomatic. What do you do? Do you do a stress test or do you do an invasive angiocardiogram to see what is happening and confirm this 90% block or not? So most people would do an invasive angiogram to delineate the anatomy to see what exactly is happening inside. So I'm showing you the CT scan. Okay, so this bright stuff is the calcium on the LAD. And you can see somewhere here, there's calcium on this side of the LAD. There's calcium on this side of the LAD. This is the left main. This is the circumflex bifurcation. And if you really look at the light white, not the extreme bright, the passage is so tight inside the LAD and then it opens up here. This really does look like a 99% blockage. But remember, what did I tell you? High calcium score, there can be a lot of interference on penetration in the lumen. But nonetheless, I told him, let me do an angiogram and decide whether you've got a 90 or 90 or less percentage. So this is the patient's angiogram. I'm not lying to you. I've written in the same manner. This is the left main. This is the circumflex. This is the LAD, and the LAD is widely open. This is not a 99% blockage. If you can just roughly imagine here, there's a calcium on the outside indenting onto the LAD, but there's no occlusive compression inside. And this patient did not need a stent. All he needs is medicines to kind of keep his LDL very low to prevent any form of progression here. Okay, so I don't know how the folks look at LDL targets, but in Singapore, in my practice, I follow the European Society of Cardiology. This is from 2025. guidelines updated from 2019. So in my mind, most patients should have a LDL less than 3. But if you have some risk factors in this chart over here, so if you have diabetes, CKD, or even imaging with arteriosclerotic cardiovascular disease, so basically high calcium score, any plaque, or any stents, you should really be targeting your LDL low to about 1.4 and sometimes even 1.8. There's a bit of nuance to that, but if you already have high calcium score, plaque disease on imaging or already known heart attack, you should be targeting 1.4 and don't accept a substandard any other value because you want to protect them in the long run. Okay, and then another thing I wanted to highlight you from the guidelines is in Singapore for risk stratification, even if they have nothing in terms of the CT scan, ultrasound carotids, no plaque, the LDL is high. I do a test called lipoprotein A, and lipoprotein A is a risk enhancer. We call this a risk enhancer. If it's high, it adds to your cardiovascular risk. So even if your LDL is high, this compounds the problem, and it's a well-known fact. So we came to realize about this lipoprotein A because we used to see patients with good cholesterol, LDL not too bad, but they still got affected by premature heart disease. And this genetic marker, 0 to 5 years of age, it rises and it plateaus for the rest of your life. So for example, different targets. This is lipoprotein A for one of my patients. It should be less than 75. He was double that. And currently, there's no medications to bring it down. If you have, you need to bring down your LDL to about 1.4, 1.8 to offset the strong genetic risk of lipoprotein A. I'm not talking about familial hyperlipidemia. This is lipoprotein A, which is a different marker, which is a risk enhancer. Okay. In 2026, the American guidelines now say that you should be looking at your cholesterol values at not 40 years of age, but 10 years earlier at 30 years. And if you've got some high cholesterol and is at intermediate risk, whatever calculator that you use, you can do a calcium score. And if the calcium score is more than 0, that means a little bit 1, 2, 3, 4, you should be initiating lipid lowering therapy. All right, so I think this is a game changer. So some patients we are pushing earlier for some form of plaque burden identification so that we can get them on medications early. Because what we used to see now in my practice, I see a lot of people riding with high cholesterols, 4 and 3.8, 3.9, and by 50s or 60s, I have to put stents in them because they have plaque disease already. Okay, so I think it's useful to also kind of have an idea of the different statins that you have. We have moderate intensity statins, high intensity statins, and moderate intensity statins bring down LDL by 30%, high intensity bring downs by 50%. So you need to know where your starting cholesterol is, your baseline, whether it's 3.4 or 5.6. And you need to know the target that you need to achieve. Do you need to achieve 3 or 1.4, 1.8? Then you can play around with the intensity of statin. Ezetimibe on its own is quite weak, about 20%. But if you pair a high intensity statin with ezetimibe, you can get about 60%. And in my high risk patients, I'm using injectables, PCSK9 injections with statins, and I can bring down the LDL to about 90%. And a lot of my patients have LDLs which are sub 1, 0.6 millimoles, 0.5 millimoles, and they're doing just fine. And I'm trying to protect them from, repeated procedures and trying to protect them from instant restenosis if I put them on stents already. So this chart is very useful to know low intensity, moderate, and high intensity. So your Crestor and your Lipitor at 40 to 80 is considered high. Lipitor, atorvastatin at 10 to 20 is moderate. Crestor 5 to 10 is moderate over there. So you can play around with the statins. I think another point I have to make is statins are not glucose neutral. Statins can change sugar metabolism, and you need to be mindful of that. But patients get worried about it. But the risk of that is far smaller than the risk of arteriosclerotic progression. And I would tell patients, don't worry about the sugar. I think the main thing should be LDL reduction. Of all the statins, pitavastatin, I'm not sure how many of y'all have that. It goes by the generic pitavastatin, brand name is Liverol here in Singapore. That is theoretically the most sugar neutral, but they are only a moderate intensity statin, and no matter how high you dose them, you will not get that 50% reduction. So it's can be used if you're really worried about sugar metabolism. HbA1c is creeping higher and higher, getting pre-diabetic. You can use this if they do not need such extreme low targets. Okay, I'm going to try to wrap up soon. So why is calcium a problem? I think if the patient has too much of calcium and I need to open up the artery, remember calcium is on the wall. It makes opening of stents difficult. There's constriction from the wall. My stents cannot expand. And if my stents cannot expand very well, there'll be stent failure in future. There's higher chance of restenosis. So before I put in a stent, when there's calcium, I need to break the calcium up, and I have to use a lot of sophisticated tools, electricity, special balloons with pulses to open up and pound the calcium, balloons with razor blades to slice the calcium like plates, and sometimes I need to use a drill to drill the calcium so that I shave the calcium. Then I can open up the stents and decrease the risk of failure. Okay, so give you an example. So I had a 63-year-old medical tourist. He came from Indonesia to see me, and he came for screening. Okay, and as part of screening, I think he had high cholesterol. I did a CT calcium score, 1,300. The calcium was everywhere, worse in the RCA. The radiologist called me up and said, Dr. Pinakin, do you want to do the angiogram, or are you happy with this high calcium? And I told them I don't need the angiogram because the calcium already is so high. There's surely something inside. I brought him for an angiogram. And you can see one of the arteries here, there's a narrowing here. The calcium score is so high. So when I use a balloon to open up, you can see the balloon opening up here. But look at the center point. There's this hourglass figure, right? Because there's a calcium on the outside and the balloon just cannot crack open a calcium. So I had to use special devices to crack the calcium so that when I open up my stent, I already put in a stent, it is not impinged. The stent is widely open and a nice passageway. So these are the tools that we can use: a drill, balloons with electricity inside, or balloons with razor blade. Okay, so I think I just wanted you all to just have an understanding of what to do in your patients. You don't need the patient to come to a cardiologist to organize a CT calcium, CT coronary angiogram. I think if you understand it, they look at different things. If you tell the patient that a calcium score will only tell you the outside the wall, it will never tell you how many percentage of narrowing inside you have. By extending with a small amount of dye, it gives you a luminal assessment to tell you the percentage. Generally, this explanation sits quite well with the patient. Because, if you just send them for calcium score, I've got patients who are annoyed. Oh, doctor, you just send me for calcium score. Okay, how many percentage of blockage I have? Then you have to tell them, no. Calcium is just look at the walls, the percentage, you need an angiogram, dye. Then the patient will say, oh, why you never do this in the first place as one sitting? Yes, there's a difference in cost in Singapore. The difference of a CT calcium and a CT coronary angiogram is about 3 times the difference. And, if you're not sure what to do, and you can always check in with a friendly cardiologist like what I've shown in my cases. You can just speak to a cardiologist and ask them, what should be the treatment diagnostic modality of choice, and that can also help. And this is beyond treadmills, because treadmills, trust me, simple treadmills that you do in your screening center can miss serious disease, because first of all, treadmills are only designed to look for blockages which are more than 80-90%. And even if they're designed to look for blockages more than 80-90%, the sensitivity and specificity is not so great. And I've had patients who had normal treadmills coming in for heart attack 1-2 weeks later. So, I mean, that's my contact details. That's my email if you need to ask me any questions. That's my personal contact number if you need any discussion with a patient. And that's my clinic website. And, I'm quite active on Instagram. I do post some interesting cases that I see, if it might help with your practice. That's all I have, folks. Thank you very much.
All right, thank you, Dr. Pinakin. We are still collecting questions.
Yes.
So, maybe I will get Dr. Siaw on stage first. There are
There's
some.
a third speaker also, right?
Yes.
Okay. Hey, hi, Dr. Siaw.
Yeah, hi, Dr. Pinakin. Thanks for that wonderful talk. Very enlightening.
Yeah.
So I
I
sent a
think
lot.
I like your talk on your talk on AI, and even the CT coronary angiograms. There's a lot of AI being introduced. So sometimes if there's a blockage on a CT scan, CT coronary angiogram, 50-70%, there's a lot of software that can now measure the flow down the arteries from the CT scan without having to go into the angiogram lab and put a wire inside to measure. So these are a lot of softwares that can, render the flow down the artery, and it's called CT physiology instead of invasive physiology.
Yeah,
It's not the gold standard,
yeah.
but if for patients who don't want to go inside, we can consider things like that.
Oh, great. Because I do send quite a lot of patients for routine CT coronaries actually. So in fact, it is quite common in my practice to find blockage of 20, 40, 60%, multiple blood vessels.
Correct. So
yeah.
correct. So I think in this kind of scenarios, they're moderate. Yeah. So I think if it's 20-30%, I think like what you do, optimize their statins, bring down the cholesterol. But if it's a bit higher grade, like 60, moderate looking, then sometimes it's worthwhile to get some form of functional assessment, because that was anatomical. Then a functional, yeah, you can do a simple treadmill or even a stress echo to just make sure that, when they exert themselves, that 60% is not causing a problem. It's like a cup, 50% full, 50% open. So some people is okay.
Right. Yes.
I think Dr. Siaw has a question, right? Alfred, you want to read out the question or?
Yes, I will read out the question for Dr. Siaw. So for Dr. Siaw, there's a question for you. It is, for aging population care, what is the most commonly overlooked clinical issue in elderly patients that primary care doctors should pay more attention to?
Yeah, thanks. I think that's a very appropriate question. In fact, as I was mentioning just now in my talk, right, a lot of time the emphasis has always been looking at the patients from the clinical aspect in terms of their HbA1c, sugar control, high blood pressures, as well as the cholesterol level. As I mentioned just now, right, actually, I find that it's not just the three high. In fact, nowadays, I tell the patient you got 4 clinical problems. It's not 3, it's 4. Basically, weight. And this is imperative for us as a primary care doctor to look at the context of weight. Now, more than 60% of my patient, at least, in fact, statistics will show 60-65%, of Singaporeans is straight overweight. Almost up to 20% is straight obese, So now weight is an extremely important clinical burden, not just in terms of cardiovascular risk, strokes, but you see actually people with overweight has increased functional risk, okay? Not only that, they've increased risk of cancers, and all these statistics were thrown in our face. So I always warn my patients, you see, now I'm not dealing with 4 problems. If I solve your 3 problems, I'm dealing with 4 problems. If I solve your 3, I say 1 more. And a lot of patients, I have drawn them to the fact that weight is not a lifestyle issue. It is a disease. The way that I treat them now is I treat them like a disease. So that will actually help to contextualize the clinical problems, you see. And I think as primary care physician, the first thing that we must do now is assess how many of your patients are actually overweight. Now, it is something very simple, easily done, you see. Just take their height, weight, BMI, and then their waist circumference. Now, you will have that contextualized, you'll be shocked, okay, what you have missed. And how much to bring the patient down to earth that is not just keeping their BP control, keeping their cholesterol and sugar control well, but weight has become a clinical markers for actually long-term health and longevities. Now, the other question is, what change in the primary care practice could make the biggest impact on preventing long-term complication in aging patients? Now, it is very important. In your primary care practice, what do you do when the patient comes to see you see? And I find that increasingly that one of the biggest things that I can do, at least with ease in the clinics, that I incorporate in the way that I take care of my patients, actually assess their functional status. Now, you'll be surprised to see one thing that's important, okay? Every patient who sit down on your chair when they consult you, whether they are in the age of 50 or even 55, ask them to stand up using one leg standing, and try the other leg. You'll be shocked to see perhaps up to 70% of your patients can't do that. Now, sarcopenia is something that as we age, you can be healthy, but you have limited mobilities. It's something that we have to be very acutely aware with. And it's something that I think many doctors have actually forget about it. Now, when I talk about aging, right, I want people to have healthy aging. Age well and live well, you see. And what is most precious to an elderly is actually the ability to do things myself, to be independent, to move, to travel to where I want to see the world, rather than somebody to take care and clean my backside for me. I think that's the worst, and that gives a lot of frustration downstream. So I hope for take home, look at the weight as part of the clinical problems. Look at the function that the patient should have. Because it is just by the way kind of screening, you could have done your patient a huge favor. Yeah.
Okay, thank you, Dr. Siaw. I hope that answered the question already. There are actually no new questions coming in.
Maybe I will have one question for Dr. Pinakin, perhaps in terms of, I think in terms of CT coronaries, in the context of CT coronaries, I think the question I want to ask is, don't you think that in an affluent society, like, do you think that CT coronary should be routinely done as a screening tool? I would say not so much as at least for a risk patient, for diabetes, patient hypertensive, perhaps at the age of 50 or 55, at least one of tools, The way that colonoscopy has been done, colonoscopy has been done, and we said after 50 years old, colonoscopy should be done at least once. At least I know. The way I approach primary care is I would very much want to know the cardiovascular status of my patient after the age of 50. You see, you give example of people with normal calcium score, with back blockage, people with seemingly normal cholesterol. I have patients with totally normal cholesterol, okay? Totally no symptoms. Then suddenly symptoms hit at the age of 65, and you find, lo and behold, 3 blood vessels, triple blood vessels, 90% block. It's not uncommon to see that. Meaning they may have abnormal apoprotein, lipoprotein A, which we don't normally routinely do, you see. Yeah, perhaps you can.
Yeah, you mentioning all this just tells me that you've been very, very vigilant on the ground. Um, yes, by the time you get symptoms, right? By the time you get cardiovascular symptoms of chest pain, breathlessness, you already have florid disease because you need to have a certain degree of stenosis before symptoms come on. And you rightly say, a lot of people will not have symptoms all the way until 70, 80%, even slightly lower grade, 60, 70, you might not have symptoms because there's this thing called ischemic conditioning.
Yep.
So you can have your arteries dilate. So even if you have plaque 70, 80% inside, your arteries can remodel to dilate to try to maintain the same patency within it. But after a while, that compensatory mechanism is no longer available and you suddenly have symptoms. So your question, Dr. Siaw, is more like a public care question and a private sector question because in the public care, I used to be in public care some time ago, and it also boils down to dollars, cents, cost of tests, and how much of abnormalities you detect. So if you send everyone for a screening, then there's a lot of burden on costs, and also how many patients you actually find to have one of these florid but silent disease. But in private care, because we are dealing and I'm doing personalized tailored medication for that individual patient, it is so important to know whether I have something or I don't have something, and I don't care about the economics of scale. So, in private, I can tell you for a fact that a lot of cardiologists, when the patients land up with them with cardiovascular risk factors, I do offer them a screening CT coronary angiogram, even if they don't have symptoms, particularly if they are mid-age and above, 50 and above. Or, don't forget the females. The other thing I want to mention is we didn't talk about, maybe not even also in your talk, that menopause, right? Menopause is a strong cardiovascular risk factor. So we talk about high blood, diabetes, cholesterol, obesity, smoking, blah, 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 genetics. But menopause in a female is also a risk factor. And the number one cause of death after menopause is not breast cancer, it's still cardiovascular. And if the patients have never had time to look into their affairs, menopause is a good time to start looking at all these blood tests and maybe even a CT coronary angiogram to kind of see where they stand. And you don't need to do a CT coronary angiogram every year. Once you have it done and it's kind of normal, not too bad, 10, 20, calcium not too high, the next one can be done 5 years later. So
Yeah,
it's a good
thanks.
surveillance.
Okay, just one last question.
Just one
What
last question.
what is the role of
What is the
troponin I
role of troponin I
as a screening?
Yeah.
as a screening?
There has been some referrals I've gotten with troponin I done as screening and is elevated, and this patient has no chest pain. So in my mind, in a lot of literature, troponin I or troponin T is mainly for acute coronary syndrome deduction. And trop I, if raised in screening, it does open up a can of worms. Of course, some patients just have high riding trop I's. If you have renal impairment, you can have high riding trop I's. Some patients have these autophyl antibodies, which can falsely elevate trop I. So I would advise don't do trop I as screening because it is not something that we have guidance for.
Okay, thanks.
Mm.
Okay, there are still no new questions coming in.
New question coming in.
So I think since I just want to emphasize one point, some of the foreign patients from neighboring countries, Myanmar, Vietnam, Indonesia, Philippines, when they don't have access to a ready CT coronary angiogram in their countries, and they are like a certain socio-economic status patients, they actually do fly over to come and see me and my colleagues to get some of this advanced cardiac screening. where they just have a ECG and treadmill and nothing much more there. And we do pick up some things.
Right. Okay. So yeah,
Yeah,
doctors are free to
doctors
refer
are
to you
free to
for your
refer to you
contacts
the context
on the
on
screen as well.
the screen as well.
Okay. So
Okay.
I think I will
So
thanks Dr.
I think I
Pinakin
will
and
thank
Dr.
Dr.
Siaw.
Pinakin and Dr. Siaw.
There are no other
There
questions
are no other
already.
questions
Thanks,
already.
Albert.
Thanks, Albert.
Thank you, Alfred.
Thanks.
Thank you.
Thanks. Thank you.
Bye-bye.
Okay, so moving on, the next thing that we'll be taking a break first before our third speaker, Dr. Priska, to come in. Right. So during this break, I will actually share something for the doctors in Indonesia. Right. Let me present my screen. Give it a while. It's processing now. Not to worry. It won't be a very long break. I will take most likely at most 5 minutes of your time. On the deck is still processing. It's taking quite a while. Right. Right. Okay, great. So, yep, for the doctors in Indonesia, so before we proceed to our final session tonight, I'll take a few minutes to share with you this exciting initiative. Right. So, as many of you know, healthcare communication and patient engagement are evolving very rapidly in today's digital landscape. Right. More patients are now seeking trusted medical information online through social media, short form video, webinars, and digital platform. Right? This initiative is designed to help the doctors become trusted digital health voices while maintaining professionalism, credibility, and medical accuracy. Right? The program focuses on helping healthcare professionals creating meaningful education content that benefits both patient and the medical community. This includes health education content, professional webinars, public awareness campaign, community engagement initiative, short form educational videos. Right? The goal is not just visibility, but trusted, evidence-based healthcare communication to the people. Right. So another key area is flexibility and support. We understand that doctors are already very busy with your clinical schedule. So the system is designed to be structured and easy to participate in, right? So the support includes content planning, assistant, professional editing support, campaign coordination, educational framework guidance, performance reporting, right? Doctors can contribute based on their area of expertise and comfort area, right? One important point is that this is not limited to one format only. Doctors may participate through educational articles, webinars, interviews, social media educational videos, health awareness campaign, public education series. Different specialties and communication style can all contribute meaningfully. Right. Most importantly, this initiative aims to build a strong and trusted healthcare communication network where doctors can contribute accurate medical information to the public while strengthening professional outreach and healthcare literacy. Healthcare misinformation continues to be a major challenge globally, and trusted healthcare professionals play a critical role in shaping public understanding. Right. For doctors who are interested in learning more or exploring collaboration opportunity, please feel free to scan the QR code right on the screen. Then you can reach out to the contact details lah, right? So I have my colleague Ananda. His contact details is on the screen, or you can email us through the email address. Then yeah, we can do something out meaningful to the public. Okay, so that is all for me. Now I will be passing it to my colleague Ananda first. He will be presenting a few slides in Bahasa.
Hello everyone, thank you Alfred. After that we will presentation and the speaker will be in Bahasa. I will take over. After that you can rest, Alfred. Thank you. Maybe first time I will share about. Let me share. Oke. Nah jadi kita akan untuk selanjutnya kita akan berbicara dengan bahasa Indonesia. Jadi buat rekan-rekan nakes dari Indonesia dan juga rekan-rekan dokter, selamat datang. Jadi tadi sudah di-mention ya sama Alfred. Ini slide-nya sudah kelihatan belum? Our side already see?
No, hang on, it's just in. Let me add in for you. Right, it's in. Okay, to you. Thank you.
Okay, thank you, Alfred. Jadi kita ada namanya program dokter influencer nih, atau juga, dan ini programnya terbuka juga untuk nakes tentunya, tidak hanya dokter, tetapi rekan-rekan nakes juga bisa mengikuti program ini yang sudah di-mention sama Alfred sebelumnya. Jadi kita sebagai nakes nih dan juga sebagai dokter itu menjadi edukator nih di sosial media tentunya. Nah, mengapa harus menjadi health influencer? Karena di era informasi digital, publik membutuhkan suara ahli nih untuk melawan misinformasi kesehatan. Nah, bersama ManaDr nih, rekan-rekan nakes dan juga rekan-rekan dokter itu bisa menghasilkan rupiah hingga jutaan rupiah cukup dengan membuat konten edukasi di media sosial. Tentunya nanti juga bisa klaim SKP ya. Nah, nanti bakalan kami siapkan briefnya dan campaign. Jadi dokter fokus pada edukasi dan juga branding. Tentunya nanti juga bisa collab dengan ManaDr di sosial media begitu ya. Tentunya ini memberikan exposure tambahan untuk dokter begitu. Nah, potensi mendapatkan jutaan rupiah nih. Tentunya nanti kita bakalan memberikan opportunity nih kepada dokter, di mana tentunya nanti ada campaign reward buat dokter jika mempost dari brief yang kita sediakan, gitu ya. Nah, tentunya ini ada extra income yang tentunya nanti dokter atau teman-teman nakes dapatkan, dan juga nantinya membangun personal branding. Tentunya kita ada content support, dan juga kita bisa wider reach, karena di ManaDr sendiri adalah aplikasi global ya. Jadi tidak hanya bisa terkoneksi dari nakes dan juga dokter dari Indonesia, tapi juga di beberapa negara. Salah satunya tadi speaker kita ada yang dari Singapura, ada yang dari dari Singapura dan juga dari beberapa negara lainnya ya. Oke, nah bagaimana cara bergabungnya? Tentunya gampang sekali. Tadi kita juga sudah siapkan registrasi formnya. Silahkan download ManaDr for Provider. Ini bisa cari di Play Store atau di App Store ya. Lalu registrasi akun dokter atau tenaga atau akun rekan-rekan nakes. Join program, lalu masuk ke fitur ManaChat. Nah, untuk infonya bakalan kita share di grup ManaChat ini. Jadi rekan-rekan nakes dan juga dokter bisa download aplikasi ManaDr for Provider dulu di Play Store atau App Store. Lalu registrasi, daftarkan akun dokter atau tenaga kesehatan gitu. Tentunya ini terbuka ya, tidak hanya untuk dokter juga, tapi juga untuk nakes. Kalau rekan-rekan berprofesi sebagai perawat atau mungkin bidan itu bisa juga gitu ya. Nah, lalu masuk ke fitur ManaChat. Nah, bagaimana cara bergabungnya? Ini dia caranya setelah rekan-rekan download aplikasi ManaDr ya. Nah, di sini setelah di-download, silahkan klik di bagian bawah bergabung dengan jaringan penyedia kami. Nah, setelah itu akan diarahkan ke website nih. Silahkan isi detailnya dan juga nama, email, dan juga nantinya ada SIP dan STR jika rekan-rekan sebagai dokter atau sebagai nakes nanti bisa dikosongin aja. Nanti bisa dibuat keterangannya profesinya adalah contoh perawat atau bidan gitu. Nah, setelah daftar lalu buka email. Sebentar, kelewatan. Ya, nah setelah daftar lalu buka email dan juga nanti bakalan diverifikasi lalu login lagi di aplikasi tadi. Nah, bisa dilihat di sini, ini adalah tampilan awal ManaDr for Provider. Nah, di bagian sini silahkan klik ManaChat ya setelah rekan-rekan dokter ataupun nakes daftar dan juga register. Nah, di ManaChat ini kita bakalan ada grup nih, grup judulnya nanti Dokter Fluencer dan Nakes Fluencer Indonesia. Tentunya ini hanya untuk Indonesia dan ini kesempatan emas sekali nih buat rekan-rekan nakes di Indonesia, buat rekan-rekan dokter di Indonesia. Tentunya ini menjadi peluang yang sangat bagus nih ya untuk rekan-rekan semuanya begitu. Nah, nanti kita bakalan share di sini. Nanti setelah itu kita bakalan ngasih brief konten dan juga informasinya di ManaChat. Jadi untuk tahap pertama, rekan-rekan harus download ManaDr dulu. Bisa di ManaDr for Provider ya, jangan salah. Bisa cari di Play Store atau di App Store, atau mungkin bisa scan QR nih yang ada di layar saya begitu. Atau mungkin tadi yang sudah dibagikan oleh admin YouTube kita. Oke. Nah, saatnya ubah knowledge menjadi income. Bergabunglah dengan komunitas dokter dan nakes influencer terbesar di Asia Tenggara. Join sekarang, silahkan scan QR atau klik link yang sudah kita share begitu ya. Nah, feel free jika ada pertanyaan bisa hubungi saya di 0851 8634 6658. Baik. Mungkin itu tadi yang bisa saya sampaikan. Nah, untuk selanjutnya adalah sesi Dr. Priska. Nah, untuk Dr. Priska akan saya bacakan untuk CV-nya. Jadi sedikit gambaran untuk Dr. Priska. Dr. Priska adalah seorang content creator. Dia adalah seorang dokter ya. Dokter lulusan dari Universitas Andalas nih, lulusan tahun 2014. Nah, untuk sekarang Dr. Priska aktif menjadi konten kreator nih di TikTok dan juga YouTube. Selain itu, Dr. Priska juga pernah mempunyai pengalaman di healthcare tentunya. Salah satunya di Brawijaya Healthcare, di Yukfit, dan juga penanggung jawab klinik di Intermediate Care. Nah, hari ini Dr. Priska akan membawakan materi yang cukup menarik juga. Yes, Dr. Priska, you can add in show.
Oke, terima kasih banyak Mas Nanda. Baik, saya langsung saja ya, semoga belum pada ngantuk. Kita akan sampaikan dengan singkat, tapi inti yang kita share itu dapat. Nah, pada kesempatan malam hari ini saya akan sharing tentang DBD di Indonesia, di mana saatnya kita shifting nih dari kuratif pengobatan ke preventif. Ini yang akan kita bahas. Nah, kenapa DBD masih menjadi masalah besar di Indonesia? Ya, tentu saja seperti yang kita ketahui bahwa Indonesia adalah negara beriklim tropis, di mana curah hujannya tinggi, kemudian urbanisasi yang tinggi, sehingga terjadi kepadatan penduduk di daerah perkotaan. Kepadatan penduduk ini mengakibatkan terjadinya sanitasi yang buruk ya, sehingga banyaklah tempat-tempat yang memungkinkan si vektor pembawa DBD yaitu nyamuk dengue ini Aedes aegypti berkembang biak. Akibatnya apa? Kasus terus muncul setiap tahun sehingga rumah sakit penuh, ujung-ujungnya apa? Tenaga kesehatannya kelelahan ya, overwork. Seperti kasus kemarin ada salah satu rekan kita dokter internship yang meninggal dunia karena ya salah satunya karena imunnya turun akibat kelelahan. Nah, tapi sekarang DBD itu bukan lagi penyakit musiman. Jadi nggak hanya saat musim hujan saja DBD akan meningkat, tapi dia bisa meningkat di sepanjang tahun walaupun akan puncak di musim-musim hujan ya. Dan dia tidak memandang usia, dari anak kecil, kemudian usia produksi sampai orang tua itu akan dikenai. Dia tidak memandang usia. Nah, apa yang terjadi sekarang? Ya khususnya di Indonesia, yaitu kita masih fokus pada pengobatan, di mana kita tunggu ada yang sakit DBD, kemudian diobati, dan pengobatannya ya kita tahu ya simptomatif ya, bersifat suportif, di mana kalau ada keluhan demam kita kasih obat demam, kemudian kita pantau tanda-tanda vitalnya, gejala-gejalanya, kemudian pastinya manajemen cairan rehidrasi. Lalu kita monitoring hematokritnya, apakah ada kebocoran ya dari plasma. Nah, lalu kita pantau juga tanda-tanda bahaya. Nah, hal ini bisa mengakibatkan terjadinya penanganan yang kurang cepat. Jadi kadang pasien yang datang ke rumah sakit itu biasanya sudah dalam kondisi yang tidak baik gitu ya, di mana kita sebaiknya lakukan sebelum si pasien sakit atau sebelum pasien harus diopname. Nah, berbeda dengan penyakit lainnya, DBD walaupun disebabkan oleh virus, itu kita belum pakai antivirus, tapi tetap inti dari terapi yang kita lakukan saat kuratif itu adalah suportif. Seperti itu. Nah, apa keterbatasan pendekatan kuratif ini adalah yang pertama, yang seperti yang saya bilang tadi, yaitu pasien datang saat kondisinya sudah buruk. Ya biasa ya, kita juga kalau sakit biasanya kita diagnosa sendiri dulu, lihat Google dulu, kemudian cari obat sendiri dulu, kemudian beli obat OTC dulu. Kalau udah nggak mempan, baru ke rumah sakit dan biasanya itu sudah buruk. Lalu karena itu ada resiko keterlambatan dan menyebabkan meningkatnya komplikasi dari penyakit DBD ini. Kemudian ketika sudah diopname terjadi lonjakan rawat inap. Lonjakan rawat inap ini mengakibatkan apa? Tenaga kesehatan pun kewalahan, kemudian pendanaannya pun akan semakin meningkat. Selanjutnya kita tahu kalau seandainya ada nih di suatu kelurahan atau di suatu RT, oh ada satu warganya terdiagnosa DBD, yang dilakukan apa? Dilakukan fogging ya. Fogging itu gunanya apa? Gunanya untuk membunuh nyamuk dewasa, vektor yang membawa penyakit DBD ini. Tapi ada keterbatasan dari si fogging. Dia hanya membunuh nyamuk dewasa saja. Sedangkan telur, larvanya itu tidak mati dengan fogging. Lalu efeknya tidak jangka panjang, hanya saat di fogging saja. Lalu juga ada risiko resistensi. Nah, kadang ada juga pertanyaan, kalau seperti itu emang masih berfungsi fogging? Masih. Fogging itu fungsinya untuk mematikan nyamuk dewasa saat itu agar rantai kehidupan nyamuk itu terputus ya. Jadi fogging tetap, tapi kita harus barengi lagi dengan tata laksana lain yang lebih tepat melakukan preventif. Karena itu kita harus merubah ya. Jadi paradigma kita mengobati penyakit DBD ini kita ubah menjadi mencegah. Jadi sebelum sakit. Karena ketika sakit, sudah terjadi sakit pada pasien, yang bisa kita lakukan hanya melakukan tindakan suportif dan pengobatan simptomatis, lalu membuat pasien terrehidrasi dengan baik. Nah, kalau kita lakukan preventif dengan benar, kita akan mencegah bagaimana masyarakat Indonesia secara umumnya tidak jatuh sakit, sehingga banyak nih rentetan keuntungan yang akan kita dapatkan. Tenaga medisnya tidak overwork, kemudian dana untuk pengobatannya tidak naik, kemudian resiko untuk perburukan juga menurun. Nah, apa yang kita lakukan agar paradigma yang dari kuratif ini berpindah ke preventif? Kita lakukan pengendalian lingkungan, pengendalian vektornya si nyamuk, perubahan perilaku dari masyarakat, dan yang terakhir kita bisa tambah dengan vaksinasi. Nah, fondasi dasar preventif yang dari zaman dulu sudah kita lakukan itu adalah 3M dan sekarang ditambah plus ya, tetap sama, ini tetap menjadi dasar fondasi untuk preventif dari DBD. Yang pertama, menguras. Kita kuras semua tempat-tempat penampungan air. Oke, mungkin sekarang zamannya nggak ada lagi bak ya. Di rumah kita udah pakai shower misalnya. Kita lihat ada nggak ember-ember tempat penampungan air? Ada nggak wadah-wadah yang terbuka akhirnya air menggenang di dalam sana? Itu harus kita perhatikan. Nah, biasanya di rumah-rumah yang sering lupa dan sering sekali ada jentik nyamuknya itu adalah di dispenser. Jadi dispenser di bagian bawahnya itu ada kan kayak tatakan dan menampung air. Nah, di sana sering itu. Karena ingat, nyamuk Aedes aegypti itu tidak hidup di genangan air kotor. Dia senang di genangan air bersih. Jadi itu harus kita lakukan pengurasan. Dan yang harus diingat juga disampaikan kepada masyarakat atau pasien kita itu adalah tidak hanya dikuras, tidak hanya tinggal buang udah, tapi juga disikat di semua dinding. Baik itu bak mandi, ember. Kenapa? Karena nyamuk itu menempelkan telurnya di dinding-dinding bak mandi ataupun di dinding-dinding ember. Dan dia masih bisa bertahan hidup walaupun airnya sudah dikeluarkan. Jadi tetap harus digosok dan dikuras. Yang kedua, menutup. Ya, kita tutup semua tempat-tempat wadah-wadah yang memungkinkan bisa menampung air. Lalu yang ketiga, mendaur ulang atau menimbun. Ya, kita bisa melakukan recycle alat-alat yang bisa didaur ulang seperti botol ya, plastik-plastik, atau kalau enggak kita timbun seperti kaleng-kaleng bekas. Nah, peraturan terbaru nih dari Gubernur Jakarta bahwa harus dilakukan pemilahan sampah itu per tanggal 12 Mei ini. Ya, semangat ya, semoga programnya berjalan supaya manfaat yang kita dapat juga tambah banyak. Nah, plusnya apa? Nah, ini juga sudah sering kita lakukan ya. Larvasida, bubuk abate, yaitu kita lakukan atau kita beri di tempat-tempat yang susah dikuras. Di masing-masing RT RW itu sudah ada jumantik ya, kader untuk melihat pemeriksaan jentik-jentik nyamuk. Nah, ini sangat bermanfaat sekali. Kalau bisa, kita bisa menyampaikan kepada pasien untuk di rumah itu ada yang ngingetin, cek di dispensernya ada jentik nggak. Jadi jumantiknya bukan jumantik kader RT RW, tapi jumantiknya kader di rumah kita sendiri. Lalu pakaian yang tergantung-gantung, itu adalah tempat rumah yang nyaman banget buat tinggalnya nyamuk. Kemudian kita bisa pakai kelambu ya. Kelambu ataupun repellent seperti ya banyak ya sekarang produk-produk yang bisa mengusir nyamuk kalau kita mau keluar ruangan atau kita sedang berada di tempat yang banyak nyamuknya. Dan yang terakhir itu kesadaran warga dalam membersihkan lingkungannya, ya melakukan gerakan PSN, yaitu pemberantasan sarang nyamuk. Nah, tantangannya apa untuk melakukan fondasi preventif DBD ini? Tantangannya kepatuhannya rendah. Ya, mungkin kalau ada kasus di suatu saat semuanya tergerak untuk melakukan bersih-bersih, kemudian membersihkan jentik nyamuk, kemudian semuanya dirapikan. Tapi setelah itu mungkin dengan kesibukan masing-masing akhirnya sudah tidak dilakukan lagi. Kemudian tempat yang padat, rapat, ya, perumahan warga yang saling berdempet itu memungkinkan adanya sarang-sarang nyamuk tersembunyi yang tidak terbersihkan. Kemudian masyarakat masih sering tidak konsisten untuk melakukan pemberantasan sarang nyamuk tersebut. Nah, kita sering dengar bahwa ada seseorang yang terkena DBD lebih dari 1 kali. Nah, kenapa bisa seseorang itu terkena DBD lebih dari 1 kali, padahal penyakit lain ketika sudah terserang itu sudah menjadi imunisasi alami aktif dan sudah terbentuk antibodi sehingga kita sudah kebal dengan penyakit tersebut seperti campak, cacar, dan lainnya. Karena DBD ini punya 4 varian, ya, ada DEN 1, 2, 3, dan 4. Sehingga secara teori seorang penduduk manusia itu bisa sampai 4 kali, maksimal 4 kali terkena DBD dalam hidupnya. Karena yang menyerang bisa jenis yang berbeda-beda. Jadi ketika diserang oleh DEN 1 muncul antibodi DEN 1, tapi ketika yang kedua DEN 2 diserang oleh DEN 2, maka dia tidak, antibodi DEN 1 tidak membunuh DEN 2. Begitu juga DEN 3 dan DEN 4. Nah, bahayanya, ini yang harus diedukasi nih ke masyarakat. Bahayanya kebanyakan infeksi DBD kedua itu lebih gawat daripada infeksi pertama. Pertanyaannya, kenapa infeksi kedua itu lebih berat dari yang pertama? Ternyata ada mekanisme yang unik dengan infeksi DBD ini, yaitu ada fenomena yang disebut dengan AD, Antibody Dependent Enhancement, di mana ketika kita terserang dengue yang pertama, itu kita kan secara otomatis tubuh kita membentuk antibody spesifik ke dengue pertama. Nah, kita diserang lagi oleh tipe yang berbeda. Oke, sini. Tipe yang berbeda. Nah, si antibody yang pertama mengenali virus dengue yang kedua, tapi dia tidak bisa membunuh virus tersebut. Jadi dia tetap mengikat virus tersebut, tapi dia tidak bisa menetralisir virus. Dia tetap membentuk kompleks imun. Nah, karena dia tetap membentuk kompleks imun, maka sel imun kita seperti monosit, makrofag itu menangkap si antibodi yang sudah menjadi kompleks imun bersama virus tadi. Karena ditangkap, maka antibodi ini malah menjadi driver untuk memasukkan si virus ke dalam sel imun kita, ke dalam makrofag atau monosit. Sehingga di dalam sel imun kita dia malah berkembang biak lebih banyak. Jadilah viral load meningkat drastis. Akibatnya terjadi badai sitokin, respon inflamasi tubuh lebih tinggi, terjadi badai sitokin, terjadi bocornya plasma dan resiko shock meningkat. Karena itu kenapa di serangan DBD kedua itu gejalanya resiko menjadi DSS, Dengue Shock Syndrome, itu jauh lebih meningkat. Seperti ini ya, jadi infeksi pertama, kemudian terbentuk antibodi, terjadi infeksi kedua, tapi antibodi itu dia kenal tapi dia tidak bisa membunuh infeksi kedua. Malahan dia akhirnya menjadi pembawa masuk ke dalam sistem imun kita dan dia berkembang biak di dalam sistem imun kita. seperti itu. Nah, risiko apa saja yang bisa didapat saat infeksi dengue berulang ini? Pertama, risiko dengue berat itu akan meningkat. Jadi saat DBD pertama oke, pas dia serangan ulang, risikonya akan semakin berat. Penyebabnya apa? Salah satunya yang saya ceritakan tadi, adanya antibody dependent enhancement tadi. Kemudian shock dengue-nya juga, resiko untuk shock dengue-nya juga menjadi lebih tinggi. Lalu terjadi perdarahan dan gangguan organ. Tapi tidak semua infeksi yang kedua itu menyebabkan lebih parah. Jadi dia tidak semua, tapi hampir lebih banyak lebih parah di infeksi kedua daripada infeksi pertama. Tapi ada yang tidak parah. Hal ini dipengaruhi oleh apa? Dipengaruhi oleh kondisi tubuh ya, kemudian usia, apakah ada penyakit komorbid atau tidak. Nah, karena kita mau shifting nih ya, kita berharap masyarakat tidak jatuh sakit. Sehingga kita shifting dari kuratif ke preventif. Nah, preventif yang sudah dari zaman bahula kita lakukan itu adalah 3M, kemudian pindah ke 3M+. Nah, ada pencegahan tambahan yang membantu memperkuat pertahanan kita. Karena dengan 3M+ tadi masih ada nih halangan-halangan karena tidak konsisten ya, yang masyarakat yang mungkin kita bersih nih, kita udah lakuin jentik nyamuk, kita urus baju yang gantung-gantung kita hilangin, semuanya udah bersih. Tapi ingat, nyamuk tidak punya KTP ya. Jadi nyamuknya mungkin berkembang biak di rumah tetangga. Nyamuknya mungkin nginepnya di rumah tetangga, tapi dia main-mainnya ke rumah kita. Akhirnya kita juga kena. Nah, salah satu pencegahan yang bisa kita lakukan juga yaitu dengan vaksinasi. Nah, tujuannya tetap vaksin itu tidak serta-merta kita, saya sudah vaksin, saya tidak akan sakit nih. Tidak. Tapi yang kita harapkan apa? Ketika kita sudah vaksin dan kita ada virus DBD masuk ke tubuh kita tidak jatuh sakit. Ya, simptomnya tidak berat. Kalau ada keluar simptom kayak demam, kepala sakit, perut sakit, mungkin bisa dirawat di rumah, rawat jalan, tidak di opname. Ya, ini juga mengurangi beban dari tenaga medis juga. Nah, seandainya harus di opname, tapi kita harapkan nanti tidak jatuh ke dengue berat. Nah, mengapa vaksinasi dengue ini relevan di Indonesia? Seperti yang kita tahu bahwa Indonesia masih endemis ya untuk DBD ini. Status endemisnya masih tinggi di hampir seluruh provinsi. Kemudian keempat serotipnya tadi ada di Indonesia. Kemudian infeksi ulangnya juga tinggi di Indonesia. Dan outbreak-nya itu tidak musiman, tapi bisa terjadi sepanjang tahun. Lalu ini potensi manfaatnya seperti yang tadi, kalau individunya mengurangi kesakitannya, mencegahnya untuk tambah berat, kalau dari rumah sakitnya berkurang, beban dari tenaga medis berkurang, biaya yang dikeluarkan ya, dan untuk pencegahan kasus-kasus berat. Nah, bagi kita seorang dokter atau tenaga medis, peran kita tuh sangat penting. Yaitu apa yang bisa kita lakukan? Kita bisa lakukan diagnosa dini. Kita harus tahu, kenali tanda-tanda awal dan gejala awal untuk DBD tersebut. Sebelum kita melakukan ini masih menunggu pasien, berarti ya pasien datang mengeluh demam, kemudian kita lihat ini ke arah DBD atau tidak. Jauh sebelum itu kita bisa melakukan preventif dan promotif. Ya, preventif dan promotif memberikan edukasi ke pasien. Tapi dok, kita kan kurang ya waktunya kadang, apalagi yang di puskesmas, pasien banyak, waktu sama pasien kurang. kita bisa melakukan edukasi di media sosial. Salah satunya tadi sudah ada ya wadah yang diberikan oleh ManaDr di aplikasi ManaDr dan bahkan dikasih insentif ya. Luar biasa, mungkin dokter bisa coba, kita bisa kasih edukasi kesehatan di media sosial. Di mana yang akan kita edukasi tidak hanya masyarakat di sekitar kita saja, tapi itu bisa seluruh masyarakat bisa di Indonesia bahkan di luar Indonesia bisa membacanya. Lalu tata laksana yang tepat, berbasis bukti, edukasi pasien tadi, dan mungkin kita bisa anjurkan vaksinasi bagi pasien-pasien yang memiliki resiko tinggi. Misalnya dia udah pernah DBD, sebaiknya lakukan vaksinasi agar terhindar dari infeksi yang kedua yang lebih berbahaya. Nah, vaksin DBD di Indonesia itu ada 2, ada Dengue dan ada Dengue. Tapi sekarang yang lebih terkenal itu adalah Dengue. Kenapa? Karena dulu yang pertama kali muncul itu adalah Dengue, di mana itu harus periksa dulu serotype-nya ya. Pasiennya harus positif. Ya, kalau seronegatif itu tidak dapat diberikan. Kenapa? Jadi pasien yang akan mendapatkan vaksin dengue itu harus pernah terinfeksi dengue terlebih dahulu baru bisa vaksin. Kenapa hal ini dilakukan? Karena dari hasil penelitian didapatkan bahwa kalau pasien yang belum terinfeksi DBD dikasih vaksin DBD yang Dengue ini, maka ketika ada infeksi setelah vaksin, dia akan seolah-olah menganggap terjadi seperti AD tadi. AD yang diceritakan di infeksi kedua tadi. Karena itu vaksin diberikan pada pasien yang sudah pernah DBD. Nah, barulah dari Takeda ada Dengue. Nah, Dengue ini tidak perlu. Boleh yang sudah terinfeksi, boleh yang belum terinfeksi. Itu bisa dilakukan dengan 2 dosis interval 3 bulan ya. Dan bisa dilakukan sejak usia 6 tahun. Jadi kalau rekomendasi di Indonesia 6 tahun sampai 45 tahun. Nah, disinilah di praktek sehari-harilah kita bisa masuk nih promotif dan preventifnya ke pasien-pasien dan masyarakat kita. Seperti yang sudah saya jelaskan tadi, kalau seandainya ada pasien datang demam, nah kita nilai nih tanda-tanda apakah ini mengarah ke dengue atau tidak ya. Sebelum dia DBD dia DD dulu, demam dengue dulu, di mana demam dengue itu hampir sama gejalanya dengan demam yang disebabkan oleh infeksi virus pada umumnya. Itu demam tinggi mendadak, sakit kepala, sakit perut, mual. Nah, ketika kita udah agak curiga nih, ya, belum muncul TK tuh, ya, kita udah agak curiga, kita kasih edukasi kalau seandainya muncul gejala-gejala bahaya, misal gusi berdarah, ya, kepala yang sangat sakit, mimisan, BAB encer, warna hitam, atau muncul bintik-bintik merah, itu segera langsung ke IGD. Kasih juga informasi perlunya rehidrasi, banyak minum. Nah, itu ketika pasien datang dalam keadaan sakit, kita bisa masuk di sana. Kalau pasien datang dalam keadaan sehat, dia mau medical check up, nah kita jelaskan resiko-resiko dengue, kemudian pencegahannya, jelaskan tentang 3M+. Sebenarnya tidak sulit ya untuk 3M+ ini. Lalu ketika pasien datang untuk imunisasi bulanan anaknya, mungkin kita juga jelaskan tentang vaksin dengue ini. Memang vaksin dengue bukan masuk vaksin yang dibiayai pemerintah ya untuk anak, tapi jika mau itu bisa dilakukan secara mandiri. Lalu jika konsultasi kita bisa edukasi tentang lingkungan rumah atau kita anjurkan menggunakan Repellent. Itu banyak sekali brandnya sekarang, mulai dari brand yang bisa untuk bayi sampai yang untuk dewasa. Nah, kalau waktunya kurang ya, nggak cukup nih ngomong langsung. Dokter, rekan-rekan medis, rekan-rekan tenaga kesehatan bisa bikin edukasi kesehatan digital dengan ya di-share di media sosial, di-share di status WhatsApp-nya, itu juga sangat bermanfaat. Sedikit saja informasi yang kita berikan itu bisa bermakna banyak bagi pasien atau masyarakat kita. Nah, strategi idealnya apa? Tidak hanya, oh ya udah saya vaksin aja kalau gitu. Tidak, vaksin itu hanya pelengkap ya. Semuanya itu harus bekerja sama. Fondasi dasarnya tetap 3M+ ya. Bagaimana kita bisa mengendalikan lingkungan dan vektor yang membawa virus tersebut. Kemudian untuk mengendalikan ini kita lakukan edukasi ke masyarakat supaya masyarakat juga tahu apa yang harus dilakukan, kenapa harus seperti ini, apa bahayanya. Kadang kita taunya DBD biasa-biasa aja ya. DBD gitu, banyak minum. Kalau tidak ada merah-merah tidak apa-apa. Besok DBD lagi. Masyarakat mungkin tidak tahu kalau infeksi DBD kedua itu akan lebih berat daripada infeksi yang pertama. Itulah tugas kita sebagai tenaga kesehatan untuk menjelaskan kepada masyarakat. Jangan sampai nanti ya kalau kita lihat sekarang dokter mau jualan vaksin nih, tidak ya. Kita di sini semuanya ini saling melengkapi. Vaksinasi juga untuk membantu pertahanan benteng supaya lebih kuat. Tapi fondasinya tetap 3M+. Nah, ini udah hampir di 2 slide terakhir kita masalah DBD ini. Dari share singkat saya, kita bisa rangkum 5 pesan yang bisa teman-teman bawa pulang. Pertama, DBD itu masih beban besar di Indonesia. Kenapa? Tadi kita negara tropis, intensitas hujannya tinggi, kepatuhan masyarakatnya kurang ya, sehingga masih outbreak-nya itu masih sangat tinggi. Karena itu kuratif saja tidak cukup. Jangan tunggu sakit obati. Tapi kita harus pindah shifting ke bagaimana masyarakat kita tidak sampai sakit. Dengan cara tadi. Dengan cara apa? 3M+. Dan bisa ditambah dengan vaksinasi. Ingat sekali lagi, informasi ini tidak akan sampai di masyarakat apabila kita sebagai tenaga medis tidak menyampaikannya. Jadi sampaikan supaya ilmu yang kita dapat juga bermanfaat bagi banyak orang. Mungkin hanya itu yang bisa saya sampaikan. Di sini ada quote sedikit. Masa depan pengendalian dengue bukan hanya pengobatan yang lebih baik, ya, tetapi lebih sedikit pasien yang jatuh sakit. Goals kita adalah pasien tidak ada yang sakit. Kalaupun tidak ada, sedikit yang sakit. Mungkin hanya itu yang bisa saya sampaikan. Semoga masih semangat ya dan mendengarkan. Saya Dr. Priska, saya kembalikan ke Mas Nanda. Boleh, Mas?
Ya. Maaf, Dr. Priska. Maybe Dr. Priska can stay here because we can see in YouTube. Maybe we have ya dokter, jadi mungkin kita cek dulu ya pertanyaan di kolom YouTube sama di form ya, apakah ada pertanyaan. Sebentar atau di form ini ya. Absen. Nah, ini ada satu pertanyaan dokter di YouTube. Pertanyaannya, halo dokter, bagaimana cara pemberantasan DBD di Papua contohnya? Waduh, ini pertanyaan ya sangat kompleks nih dokter. Ya, mungkin
Luar
boleh
biasa ya.
digambarkan saja dokter kira-kira bagaimana?
Iya, untuk pemberantasan ya saya pribadi itu tidak bisa memberikan solusi konkret karena ini memang akarnya itu dari atas sampai bawah itu harus bekerja sama. Sudah ada juga satu inovasi yang dilakukan yaitu dengan memasukkan bakteri Wolbachia ya ke dalam nyamuk, di mana itu bisa menyebabkan virus dari dengue ini tidak ada di si nyamuk. Sehingga jadi intinya kalau untuk DBD harus ada 2 nih. Nyamuknya harus ada, virusnya harus ada. Kalau nyamuknya ada, virusnya nggak ada, walaupun kita digigit oleh nyamuk Aedes aegypti ini, kita nggak akan sakit karena nggak ada virus di dalam si nyamuk. Nah, kenapa si nyamuk punya virus? Karena dia gigit orang yang sakit. Gigit orang yang sakit, masuk ke dalam darah nyamuk, terus gigit lagi ke tetangga. Dia mindahin si virus. Nah, kalau virusnya nggak ada di nyamuk, maka dia nggak bisa nularin. Sehingga DBD tidak berkembang. Yang kedua, tadi virusnya yang nggak ada ya. Nah, sekarang nyamuknya nggak ada. Jadi kita buat si nyamuk nggak ada. Misalnya ada virus, satu pasien nih di suatu kelurahan terkena DBD, tapi nyamuknya yang akan memindahkan vektornya itu dari satu orang ke orang lain tidak ada, maka dia tidak akan berkembang. Jadi kita akan mengendalikan si nyamuk. Dengan cara apa? Dengan cara 3M tadi. Nah, pemerintah juga sedang melakukan percobaan, untuk Wolbachia tadi, memasukkan si bakteri Wolbachia ke dalam si nyamuk sehingga si virus itu tidak bisa hidup di si nyamuk. Seperti itu. Kalau bagi kita masyarakat dan kita tenaga medis, ya kita akan sarankan ke masyarakat untuk melakukan 3M+ tersebut. Itu supaya si yang nyamuk nggak ada, sehingga nggak bisa menularkan gitu.
Iya, nah kurang lebih itu ya pencegahannya jadi dengan 3M dan juga memberikan vaksin nih agar virusnya itu tidak ada ya dokter ya, dan juga tentunya
kalau vaksin bukan virusnya tidak ada, itu vaksin untuk meningkatkan kekebalan tubuh kita. Kalau yang virusnya tidak ada itu memasukkan bakteri Wolbachia tadi ke si nyamuk.
Oh baik, berarti salah satu cara pemberantasannya memasukkan bakteri Wolbachia tadi ke nyamuk ya dokter, sehingga
yang dicoba dilakukan oleh pemerintah.
Ya, mungkin ya itu salah satu solusinya ya dokter, sehingga virus yang ada di nyamuk tadi tidak berkembang dan juga tentunya nyamuknya tidak membawa dengue fever ya dokter ya. Dan
kalau sekarang kalau saya pribadi itu sih 3M+ itu udah
3M+ ya dokter ya. Ya mungkin dari kakak yang rekan-rekan yang bertanya di YouTube nih, mungkin boleh disarankan buat rekan-rekan di sana untuk 3M+ begitu ya, agar terhindar dan juga bisa memberantas tentunya dokter ya. Mungkin hanya itu pertanyaan, sudah tidak ada pertanyaan lagi. Nah, mungkin aku mengingatkan kembali bagi rekan-rekan yang mengisi absen itu bisa melalui link yang sudah kita pin, dan juga bagi rekan-rekan yang tertarik nih menjadi tentunya tadi ya seperti dimention Dr. Priska menjadi edukator nih, tentunya juga mendapatkan fee dan juga intensif nantinya dari ManaDoc. Itu bisa scan yang di atas kita ini. Nah, itu bisa scan atau bisa cari di download di Play Store dan juga App Store ManaDr for Provider. Ya, terima kasih Dr. Priska untuk waktunya dan juga narasumber kita yang luar biasa sekali. Thank you for our narasumber wonderful Dr. Siaw, Dr. Pinakin, and Dr. Priska. Thank you everyone. We will close the webinar and see you next time and bye-bye.
Okay, thank you. Bye.